सही है, सही है ना, सही है ना।
वाइट डिवाइस
चलेगा, चलेगा ना।
थोड़ा सा ऊपर उठाओ ना इसको।
वो लाइट दिखेगी क्या मतलब, तो फिर वो थोड़ा सा
ठीक है,
कोई लैपटॉप आता है उसके बाद तो दिखता नहीं है।
सही है।
ऐसे मैसेज किसी को ज्यादा सारा सब
हमारा एक ग्रुप है, उसमें डाल दिया उसको एक्टिव ऐड बढ़ जाएगा, ये भी देखेंगे। चलो देखो सर, ये भी सब काम होता है, इसके बाद और एक
Very good morning to all our students. I would request all of you to please settle down.
ऐसा कुछ नहीं, आपका मेरा नहीं, सबका, बट सबको सारी जगह का इन्फॉर्मेशन होना चाहिए। वो लोग अपना कर लेंगे, ये हमारा नहीं।
All the students, please settle down. And this is waiting for your please. So, very good morning, everyone. I am Dr. Chavi Vijay, Assistant Professor in the Department of Physiotherapy, and it is my privilege to welcome you all in the ICAP 4.0, the International Conference in the Advancement of Physiotherapy, centered on the highly significant theme cardiovascular diseases and stroke. On behalf of University of Engineering and Management Jaipur, I extend a very warm welcome to all our distinguished dignitaries, eminent speakers, delegates, faculty members, clinicians, researchers, and dear students. Your presence makes this academic gathering truly meaningful. Today brings together expertise, experience, research, and clinical practice with a shared purpose to advance physiotherapy and strengthen its contribution. To begin this auspicious occasion, let us seek the blessings of Goddess Saraswati, the embodiment of knowledge and wisdom. We shall now proceed for the ceremonial lamp lighting, and so I would request all the dignitaries to please come forward for the same.
छवि को भेज दी।
May this light continue to guide us towards knowledge, innovation, compassion, and excellence. I would request all the distinguished dignitaries to please take their designated seats. But first of all, before we move ahead, I would request our Honorable Vice Chancellor, Sir, Professor Dr. Krishna Joy Chatterjee, our Honorable Registrar, Sir, Professor Dr. Pradeep Kumar Sharma, Sir, our Honorable Dean Academics, Professor Dr. Mukesh Yadav, Sir, Avtar, Sir, HOD, Sir, BP Gupta, Sir, and K. Pradeepa, Ma'am, to please take their respective seats at the dais. Please welcome everyone with a huge round of applause. Thank you so much, sir and ma'am. I now request all the dignitaries and participants to kindly stand for national song. Please be seated. Our Honorable Chancellor Ma'am, Professor Dr. Badani Chakraborty, and Director Sir, Professor Dr. Satyajit Chakraborty, could not join us today online, so they have sent their best wishes for this conference. Moving ahead, it is now my privilege to invite our respected Vice Chancellor Sir, Professor Dr. Vishnujoy Chatterjee, to address the gathering and formally share his perspective on this important academic initiative. Please welcome Sir with a huge round of applause.
You can understand the immense, I believe you understand that the immense difficult position I am in, because I have been called to deliver the first address of a conference where all the eminent personalities, the dignitaries, the most knowledgeable persons of the field are sitting on the stage and sitting right in front of me. And I am having to deliver the first address for that in the field in which I know very little. But still, because it is my responsibility to welcome and set the tone, so I will tell a few things to my dear students over here, and I will tell the same things that I told yesterday. Yesterday, many of you were present, and for sure, when I delivered that address during the workshop, and I will tell the same things to all of you. I will tell that, see, you people are going to be doctors. There is no doubt about it. You may say that we are going to be physiotherapists, but after all, physiotherapist is also doctor. It is your responsibility as a doctor to cure the society, cure the people in the society. Now the points associated over here is that once you become a doctor, please think of the society and how you are looked upon. Please rewind for a while and go back to your days, go back to the childhood days, when you used to be maybe a little sick, and how your parents used to think or look for a doctor. With all beliefs that whatever has happened to my child, the doctor will be able to cure. It's right, so that is how the society looks upon it. If there is any question, if there is anything that the society wants to know, needs to know, then they will always believe we have a doctor in our society, we have a doctor in our locality. Let's go and consult with him. Is not so. It is always the doctors who are considered to be the most important people in the society. And dear students, please understand, please realize, please think that you are going to be those most important people in the society. I'm only going to tell that when it happens, you are having enormous power. You're writing you're a doctor, automatically gives you enormous power. And with great power comes great responsibility. Please don't forget that. With great power comes great responsibility. And now it is your responsibility to build a good society. It's not so. It's not so. So the thing is that you will have to exercise those responsibility in the most responsible way. You will have to be responsible while you exercise your powers. Yesterday also I gave this example that suddenly you are sitting you think you are sitting in your chamber, and for example an accident, some accident has happened just outside your chamber. Few people suddenly brings in a person, holding a person to you and says, डॉक्टर साहब देख लो एक्सीडेंट हो गया. You believe me, for the next 10 minutes, what you do will decide whether this person will survive or he will not. What you do will decide whether he will survive in a good condition or in not a good condition. It is your responsibility for the next 10 minutes. Will you have a teacher to call upon at that time? आपके पास कोई टीचर रहेगा जिनको फोन करके पूछ लोगे? Not possible. कोई आपके पास कंसल्टेशन के लिए आए, can you call your teacher and ask, sir ये केस आया है मैं क्या करूं? Can you do that in front of your patient? No, you cannot. Now you can do. But you are still unable to visualize that situation. I'll request you, dear students, please exercise your responsibility in a proper way so that you realize that now it is time, these 4 years, when I will have to be very responsible towards acquiring my knowledge, towards my studies, so that after this 4 years or 5 years, I will be able to exercise the knowledge that I have got, exercise my responsibilities in a proper way. That is what I am going to tell you. Dear students, it is my immense pleasure to welcome such dignitaries who are present over here. Dr. V.P. Gupta sir is very much a part of our university. He is a board member, he is a member of our board. So every time we do a board meeting, at least twice in a year, we get to understand from him that what are the things, what are the changes that are happening, and accordingly we can perform our tasks or perform our duties. So it is him that we are thankful to for maybe channelizing our studies or channelizing our responsibilities towards you, towards our dear students in the right direction. Thank you, sir. Thank you for coming every time. And I'm very thankful that you are over here. Thanks to you. And thank you, sir. Thank you for coming. Thank you, sir. Thank you, madam. Thank you, madam. Thank you for coming over here. Thank you, sir. Thanks to all of you for coming over here. I'm sure that your deliberations will make this day wonderful. And I will be sitting. I will also try to echo something, some knowledge, which many think I may not need, but still I will try to get those glimpses from you throughout the whole day today. Thank you for doing this on a Sunday. There will be nobody to take me away for some other tasks. So thank you for doing this on a Sunday. So I will also be able to hear from all of you. Thank you so much. Waiting for a wonderful day.
Thank you so much, sir, for encouraging us to continue striving for excellence in education, research, and practice. Now, I invite our respected registrar and provost of UEM Jaipur, Professor Dr. Pradeep Kumar Sharma, sir, to address the gathering and share his thoughts on this occasion. Please welcome sir with a huge round of applause.
Very good morning. Is audible at the last bench? Wait. See, when we remember the last year ICAP, standing on the same dais with some dignitaries, and now if we see and compare, I think we can say screen is improved, increased, and the participation is also increased. From, you can say, the number of participants in workshops, presentations of research papers, and the outcome of the conference, definitely this time will be in a very much larger scale. And I am very much proud to say that the last year, after ICAP 3.0, university has gained big in research and innovations due to all our students. let me inform all the members over here, sir, that last year, in 1 year only, we received 15 patents granted. In 1 year only. We started filing the patents from 22-23, but the results came last year, and around 50 to 60 patents are in line. But 15 we got in one academic session. That's a very big, you can say, achievement for our students, faculty members, and university also. During last 1 year, due to all the efforts of our students and faculty members, sir, just let me inform that we jumped around 500 plus places in Times Higher Education Global Ranking. We are now placed in 1000 ranks, but earlier, last year, it was 1500 plus ranks. So in all SDG goals, we have jumped 500 plus ranks this year. It's all due to the efforts and work of our students in all the streams. Let me inform again that during last one academic session after ICAP 3.0, Physiotherapy department has more than 25 copyrights granted. More than 25. It's all due to the students and faculty contribution. Let me again inform you that since last 8 years, almost 9 years after 2018-19, when we first participated in Institutions Innovation Council under AICT initiative of innovations, due to the students' participation, again last year we stood, you can say, after BITS Pilani in Rajasthan, one of the top institutions under innovations. So my point is, this type of conference when you are attending is basically gives you an idea what actually are available where right now you are not getting, and you basically need to connect with the right person of your interest. You have to make the connections and the networking with the person to whom you want to get some lessons in your life. Believe me, today, the persons sitting on the dais, sitting in here in this particular seminar hall, if you personally give some application to meet him or her in their office, I think you will not get appointment easily. But today, sir, I am not wrong, actually.
Yeah, that is true.
Yes.
That is true. Absolutely.
If you go to AIMS and ask, sir, right now I think you are but if you go to VP sir office, you will not get an appointment. Any of the personnel sitting here. But right now, today is the day when you can connect with all of them. During your conference, you can interact, you can ask your questions, your query will be resolved immediately. During lunch hours, you can connect with them and get some contact details, so that when you will go to those hospitals or clinics for your postings, internships, or for your jobs, they will help. And I request all the persons, all the dignitaries over here, these students of ours are definitely doing good, and to remain in the same path, we require your guidance and blessings for next few years or coming many years, so that our students can definitely be in a good position in the field of physiotherapy. I hope this conference will give you some, you can say, insights of what is going on in the physiotherapy field right now. And I request Azaz sir to elaborate on this also, because he is actually having offices in different countries and trying to get whatever means globally is happening. I hope many of us are here who can enlighten all students. But I request all of you, all students, to please get connected and try to explore more opportunities. See, opportunities are there, but possibilities of connection are today. So you please explore today's day. You can say with 100% of your efforts and get the contact details. I am challenging you. If you can get the contact details of all and show to the coordinator, I will give you one chocolate. Okay. Every each one of you should get the contact details of all and show to the coordinator Neha ma'am. Thank you.
Thank you so much, sir. Now, it is my pleasure to invite our respected Dean Academics and Foreign Relations, Professor Dr. Mukesh Yadav, sir, to address the gathering. Please welcome sir with a huge round of applause.
Good morning, everyone. Respected Vice Chancellor, sir, respected Registrar, sir, all the dignitaries sitting on the dais, off the dais, dear students, faculty members, and all the persons sitting in this hall. First of all, I would like to welcome all of you for this ICAP 4.0 conference. This conference we started in the year 2023 and we are successfully doing it each and every year. This is the fourth year where we are doing it in continuity. And I would like to share a few things with you. I was passing through one physiotherapist clinic and I found one interesting quotation written on it. जान है तो जहान है, इसीलिए फिजियोथेरेपिस्ट महान है. I was actually wondering that yes, physiotherapists are great people because अगर मेरा ये हाथ जो है उड़ेगा ही नहीं तो मैं खाने का निवाला कैसे लूँगा? So ultimately I have to go and see the physiotherapist. If I have some pain in my leg, I cannot walk, I cannot do anything, any course of my life. So I think physiotherapist is such a profession कि ये सेवा भी है, इसमें पैसा भी है और इसमें मन की शांति भी है. So I think you should be proud enough to be in this profession. This is a wonderful profession, and as sir has already mentioned, you people are doctors. You people are the ones who give relief to the patients. So I'm really honored to speak in front of you. And also I would like to say one more thing, that in medical profession I think two things are very important. One is knowledge and another is hands-on practice. And how will you get this knowledge? For this knowledge you have to attend lectures, you have to read the books, you have to read those boring pages. जिसको आप boring बोलते हैं ना, मैं guarantee दे सकता हूँ, all these experts who are sitting here, they have got this expertise because they have read each and every word of the books. Without having reading books, you cannot develop that knowledge. So you have to read those so-called boring pages, or you will have to attend those boring lectures, but you have to do it because that will give you the exact knowledge. That will give you the knowledge. I have seen too many practitioners when I go to their office, they treat the patient as well as if they have a book in their hand, they are reading some book. So that knowledge, they are always updating their knowledge. They always keep reading books. So please make it a habit of reading books and do hands-on practice. मैं आपको बहुत अच्छा मोटिवेशन लेक्चर, सपोज मुझे आपको किसी बैटल के लिए ले जाना है, मैं बहुत अच्छा आपको 100 लोगों की टोली ले जानी है, मुझे बहुत अच्छा मोटिवेशन लेक्चर दिया आपको, हम ये करेंगे वो करेंगे, लेकिन अगर आप ट्रेंड ही नहीं है, कैन यू विन दैट वॉर? if you don't have the skills, techniques, how to fight in the war, will you be able to win that war? Similarly, आपके प्रोफेशन में जब तक आपको नॉलेज नहीं होगी, जब तक आपको टेक्निक्स का नहीं पता होगा, जब तक आपको उसके इनसाइट्स स्टोरीज नहीं पता होगी, बिल्कुल इंसाइट नहीं पता होगा, जब तक आपके प्रोफेशन में आप सक्सेसफुल नहीं हो पाएंगे. So I suggest you that these kind of conferences are a very good platform to develop those skills, to develop those techniques, to learn from the workshops, to learn from these experts. These experts, they know the nuances of any injury. तो आप इनसे सीखिए. आप लोगों को बहुत फक्र होना चाहिए कि आज जितने भी एक्सपर्ट्स यहाँ बैठे हैं, ऑल ओवर इंडिया से ये लोग आए हैं. Different parts of India they have come here. As sir said yesterday, they have their own, routine. They have their own schedule. They have own works. But leaving all those works, they have come here to share their experiences with you. To share their... You should at least give them this much respect that you listen to them carefully. आप उनकी एक-एक चीज को सुनिए, because I believe a building can be strong जब इनकी वॉल स्ट्रांग है, ये दीवारें स्ट्रांग है, तभी बिल्डिंग स्ट्रांग होगी. और ये दीवार जब स्ट्रांग होती है जब इसकी एक एक ब्रिक स्ट्रांग हो. तो आप वो सब एक एक ब्रिक हो. आप जब इंडिविजुअली स्ट्रांग होंगे तो फिजियोथेरेपी प्रोफेशन अपने आप में स्ट्रांग होगा. I take a leave now, and I hope this conference brings you knowledge. It adds knowledge. It adds new dimensions to your life, and you should always be proud of your profession. In fact, I will say कि जो बैचलर्स लाइफ होती है वही लाइफ जब आप पीपीटी कर रहे हैं, तो ये वाली जो लाइफ है इस वाले फेज में सबसे ज्यादा लर्निंग होती है. उसके बाद आप एमपीटी करने जाएंगे तो वो एक स्पेशलाइजेशन होगी, एक एक्सपर्टीज होगी. लेकिन जितनी लर्निंग है वो इसी फेज में होगी. So give your best, take 100% benefit of this workshop, these conferences, and do good in your life and make India great. Thank you.
Thank you so much, sir, for your bold and insightful words. Physiotherapy is a profession that continually evolves through education, evidence, innovation, and compassionate patient care. To share his perspective on this conference and the role of physiotherapy in advancing healthcare, I invite our respected Dean of Physiotherapy, Dr. Avtar Koi sir, to address the gathering. Please welcome sir with a huge round of applause.
सभी आज गेस्ट पूरे इंडिया से, आउट ऑफ इंडिया से आए, आप सबको बहुत वेलकम. और सभी ऑर्गेनाइजिंग कमेटी और डियर स्टूडेंट्स, कॉन्फ्रेंस का जो ICAP 4 ये चौथी बार जो यूनिवर्सिटी में हो रही है, तो पूरे इंडिया से ये चौथी बार पूरे आपके सीनियर्स, आपके जो आप लोग हो 4 साल से पढ़ रहे हो, आप नेशनल और इंटरनेशनल स्पीकर्स पूरे इंडिया में, आउट ऑफ इंडिया में, पूरे वर्ल्ड में किस तरह के एकेडमिक एंड प्रैक्टिकल क्लिनिकल में किस तरह की रिसर्च हुए, क्या क्या नए एडवांसमेंट आया ट्रीटमेंट के अंदर, क्या क्या रिसर्चेस हुई है, तो आप सबको सुनने को मिला. और आज मैं सभी जो आप गेस्ट आए हैं, मैं चाहूंगा सभी बच्चे एक बार जोरदार ताली बजाएं. और आप सभी को सब ऐसे बता दिया सब कि अपना आप लोग ये सब लोग लीजेंड्स हैं फिजियोथेरेपी के. वीपी गुप्ता सर बैठे, सब लोग हम जैसे लोग सब आप जैसे बनना चाहते हैं. तो सर आपके चित्रों पे चल रहे हैं, तो आपका तो सर आज पूरे दिन जो भी फ्रेंड्स और सर लोग जो आज पूरा दिन आपको फिजियोथेरेपी के बारे में बताएंगे. फिजियोथेरेपी एट प्रेजेंट में कहाँ पहुंच चुकी है, उसमें क्या क्या रिसर्च हो चुके हैं, क्या क्या प्रैक्टिकल, क्या क्या एकेडमिक, क्या क्या थ्योरिकल पार्ट, आपको किस तरह से आपकी स्टडी करनी चाहिए, किस तरह से आपको एडवांसमेंट किस तरह से अपने आप में ग्रोथ करनी चाहिए, वो सब लोग और आपको बताएंगे. तो आप सभी से मेरा रिक्वेस्ट है कि कॉन्फ्रेंस का मतलब ये होता है कि अपने ज्ञान की बढ़ोतरी करना. तो आज आप लोगों को मौका मिला है और सर ने बताया है कि सर लोगों से मिलने के लिए समय चाहिए होता है, और यूनिवर्सिटी ने सबसे रिक्वेस्ट करके इनको अपने यहाँ बुलाया, अपने घर पे परिवार कैंपस में. तो आप सबको सीरियस होके और क्या चल रहा है एट प्रेजेंट में उसके बारे में जो पूछ सकते हो सर लोगों से आप पूछिए, कोई शर्माने की जरूरत नहीं है। आप लोग, सर लोग आपको बताने के लिए यहाँ पे आए हैं, तो आप ये नहीं कहें कि हमको क्या आप लोगों को नहीं पता इसलिए बताने आए हैं। तो आप लोग कोशिश करिएगा जितने ज्यादा से ज्यादा विषय से आप लोग ज्ञान लीजिए और अपने फिजियोथेरेपी फील्ड को बढ़ाइए और खुद को बढ़ाइए। थैंक यू।
Just one thing before we continue. At the starting, I missed out on reading out the names and designations of each member who's present over here. That is my responsibility. So I did not do it. I think I should have done it. So just give me a minute of time. I wholeheartedly welcome Dr. V.P. Gupta, who is a former chief physiotherapist and head of CTBS Physiotherapy, AIMS, New Delhi. And he is a consultant CTBS physiotherapist at Fortis Escort Heart Institute in Okhla, New Delhi. He is a professor of practice in Department of Physiotherapy of Manav Rachna IIRS, Faridabad, Haryana, and is a member of Delhi Council for Physiotherapy and Occupational Therapy. I wholeheartedly welcome Dr. K. Pradipta, who is MPT Sports, CMPT, DAQ, DPT, MIAP, PhD, Fellowship in Sports Rehabilitation, and founder of Fishcraft Super Speciality Physiotherapy Clinic. I wholeheartedly welcome the keynote speakers also. The keynote speakers are Dr. Pradeep Kumar Sharkar, who is the Chief Physiotherapist of PGI MER, Chandigarh. I wholeheartedly welcome Dr. Ijaz Asai, who is the Director of AXI Physio and Fitness Center in Mumbai. He is the Chairman of Indian Association of Physiotherapists Innovation Committee of West Zone. I wholeheartedly welcome Dr. K. Madhavi, who is the Professor and Principal of the College of Physiotherapy, SBI MS University, Tirupati, Andhra Pradesh. He is the Chairperson of Andhra Pradesh State Allied Healthcare Physiotherapy Professional Council. Also, I wholeheartedly welcome Dr. Tyagarajan Subramaniam, who is a PhD Professor of Cardiopulmonary Physiotherapy at Lovely Professional University, Punjab. Dr. Mehul Contractor, who is an MPT PhD, Director and Founder of Himaya Multi-Speciality Hospital at Vapi, Gujarat. I wholeheartedly welcome Dr. Richa Hinendra Rai, who is a Professor of Delhi Pharmaceutical Sciences and Research University at Delhi. I wholeheartedly welcome Dr. Mehul Contractor, who is a PhD Scholar, Cardiopulmonary Speciality, with 15 plus years of academic experience. He is a resource person for the workshop. And other than that, I also welcome Dr. R. Arun Nozi, who conducted the workshop yesterday, Professor of Department of Physiotherapy, Sardar Bhagwan Singh University, Dehradun. He specializes in neck pain, headache, low back pain, soft tissue conditions, and sports injury rehabilitation, and he is a PhD from Punjab University with extensive practice and teaching across India and abroad. Did I miss anybody? I feel like I missed somebody. Neha madam? Sure. I did not read out sir's designation.
Sir is Dr. Anshit Gurnani. He is director in Amity University.
Yeah, so Dr. Gurnani, Ankit Gurnani, Anshit Gurnani, right? I know you very well, sir, but you know when I'm talking at stage, I tend to forget. He is a director of Amity University, director of physiotherapy at Amity University. And did I say other people's name over here? I only found. Okay. Thank you so much. Thanks to all of you. I really believe I again thank you all for coming over here. And whatever the university standing is, especially in the physiotherapy department at the moment, today at the end of this conference, I'm sure the university will go 1 or 2 levels, or maybe 3 levels upper than that. I'm sure with the presence of such dignitaries over here. I really believe that for us it is magic, for you it is the skill. The doctors treat with the help of medicines, but you treat with something which is magic for us, skills for you, skills of your hand. So I'm very, it's my wholehearted regards to all of you. I'm thankful for this entire thing. Thank you so much. Thank you.
Thank you, sir. Now, I would like to invite our respected head of the Department of Physiotherapy, Dr. Gaurang Singh, sir, to please address the gathering and formally welcome the academic and professional community participating in ICAP 4.2.
sir. Good morning, everyone. I feel really happy to welcome all of you to ICAP 4.0. Today is a very special day for our department because so many senior physios, experts, and students have come together. I want to thank our Vice Chancellor, sir, Registrar, sir, and Dean, sir, for their kind words and blessings. Their support really means a lot. I also want to thank all our keynote speakers and mentors who have taken time out from their busy schedule to share their knowledge and experiences. It is because of people like you that events like this become meaningful and successful. For our students and young budding physios, this conference is a great opportunity who have years of experiences and have worked really hard in their respective fields. Please listen carefully, ask questions, and make the most of today's session. Physiotherapy is a rapidly growing field. New research, new techniques, new ways of helping patients. Conferences like ICAP help us stay updated and help us become better than what we were yesterday. I once again welcome our esteemed panel, keynote speakers, faculty members, and students. I hope you all imbibe something today, and I hope you enjoy this conference. Thank you so much. Thank you.
Thank you, sir. It is now time to formally welcome our keynotes and experts for today's conference, whose insights will enrich our understanding and advance the dialogue on cardiovascular diseases and stroke rehabilitation. So I would request all the members on the dais to please welcome our distinguished guests. First up is Dr. V.P. Gupta, sir. Please give sir a huge round of applause. Next, I would like to invite Dr. K. Pradeepa ma'am. Please welcome ma'am with a huge round of applause. Next up, I would like to invite Dr. Pradeep Kumar Sarkar, sir. Please welcome sir with a huge round of applause, everyone. I hope you all have had your breakfast. Is that right or not?
Yes, sir.
Then please show some enthusiasm. Very welcome, sir. Now I would like to welcome Dr. K. Madhavi ma'am. Please welcome ma'am with a huge round of applause. Very welcome, ma'am. Now I would like you to welcome Dr. Ejaz Ashai. Please welcome sir with a huge round of applause. Now please welcome our next keynote for the day, Dr. Tyagarajan Subramaniam, sir. Please welcome sir with a huge round of applause, everyone. Very welcome, sir. Now I would like to welcome Dr. Mehul Contractor, sir. Please welcome sir with a huge round of applause. Dr. Richa Neendra Rai ma'am. Please welcome ma'am with a huge round of applause. Now it's time to welcome one more eminent personality who is present among us, Dr. Arun Moji sir, who conducted last year's workshop. Please welcome sir. With a huge round of applause again. I would also like to welcome and felicitate one esteemed member of our scientific committee, Dr. Anchit Gurnani sir. Please welcome sir with a huge round of applause.
So we are very well connected in LinkedIn also. But the thing is that like quite very nice.
Thank you so much everyone. Please take your designated positions. We now move towards the expert segment of the conference. It is an honor to introduce our distinguished expert, Dr. V.P. Gupta sir, whose extensive experience in cardiovascular and cardiothoracic physiotherapy brings immense value to today's scientific program. Since sir has been officially introduced by our Honorable VC sir, so I would just directly get to the point and invite sir to give his address. Please welcome sir with a huge round of applause everyone.
Yeah, very good morning, everyone. Honorable Vice Chancellor, sir, Registrar, sir, Dean, Dr. Deepak, Dr. Varun, and Akhtar. I'm really thankful to be the part of this wonderful university where I can see the only health profession happening in this university of Israel. And that's achieved this great heights. This is the third year, consecutive year which I am visiting the university. And every year I'm finding the new developments and growth of this university in a very steep level. I thank all the faculty, the organizing committee, Dr. Neha and Dr. Akhtar for inviting me to be amongst you. I'm sure what you must have learned yesterday in the workshop and you will learn today and tomorrow. Tomorrow is also, I think, post-conference workshop of Dr. So you will learn the different aspects of physiotherapy perspective. I'm sure you must have joined physiotherapy after going through so many professional updates, right? How many of you were interested in physiotherapy from the very inception after passing your 12th? How did you incline towards the health profession? And how did you come to physiotherapy? That you must have imbibed the journey, you must have lived that life, the struggle which you must have faced to reaching to this side that you got selected in physiotherapy. And you would be, as already Vice Chancellor sir and Registrar sir has told, physiotherapy is a distinguished health profession. Initially, and you would come to know that if you go to the archives of physiotherapy, this is the youngest health profession which has come to the fore of medical fraternity. The profession came after the onset of World War II and the outbreak of polio. And the organized professional status came in 1942. So we are just 80 years old, and you must have learned the history of other medical professions which are ages old. They have reached to the status at this level that healthcare delivery system has become so strong, and physiotherapy is one of them within 80 years. So you all must be proud of joining this profession, wonderful profession. I always believe and I always compare this profession to the surgical skilled professions. We use our hands as our tools, right? You must have seen the surgeons, the physicians, surgeons, lot of other professions. They require tools with their hand, in their hands. But we develop our tools inside our hands itself. And for that, developing the tools inside our hands, you need to be very practical. You need to be very sincere in learning, very dedicated in listening to your faculty, learning with your patients, and seeing the updates, what are going to be in your future years when you enter the profession as a professional. You must be happy that you are entering the profession as a transition phase. The profession was unregulated when it came to the fore. I always said that this is the journey of a profession which itself tells that how profession is needed in the society. That when I joined the profession, I did not know about physiotherapy. Just after entering into medical fraternity, just competing for the medical field, I chosen this profession after 1 year, complete 1 year, in the second time of my attempt. Both the times I got selected for physiotherapy, I did not join. Second time when I came to know about it through one of my relatives, she was an intern in Cardiopulmonary hospital in 1981. At that time, she told me that yes, physiotherapy is the medical profession which will give you a skill which does not require any extra tools. So you have to develop your tools into your hands. And at that time, there were only 6 institutions all around India, giving only 39 strength of physiotherapy professionals yearly. And all of the professionals were very much in demand abroad. So the whole batches used to migrate abroad. We were only a few left, fortunately or unfortunately, because of our intentions. But we are proud to be serving our own fellow citizens here. Because the demographic profile of our own country is totally different from the profile of the other countries in the world. Most of our colleagues, they used to migrate to Europe or European countries or American countries. So there, the profile of profession, the demographic profile which they were treating with or where they were living in, it was totally different, and they got imbibed into that. But here, the advent of the healthcare delivery system, because you have been seeing the growth of healthcare delivery profession, healthcare delivery system in India itself. And you know, when I joined, there was no regulatory body for physiotherapy. So when people used to try for abroad, they used to compete with foreign graduates. And the equalization of their credential was a great task at that time. But now, 3 years back, in India, the Central Regulatory Authority has been established for physiotherapy also. And I can see the first member of our commission, Dr. Madhvi, is here. That commission, the interim commission, has done a wonderful job for establishing the regulations which will govern the physiotherapy standards, not only in education but also in practice. So what is the advantage of regulations? Regulations, no one likes the regulations, no one likes the boundaries. But the minimum regulations have to be set in to set minimum standards of practice, because as the Vice Chancellor has said, You have an accountability, you have a responsibility towards the society. You are not a simple professional, you are a healthcare professional. A complete healthcare professional where you can work, where you can practice your profession with autonomy, but you have to be dignified, have your self-respect and esteemed, proud that you are a physiotherapy professional. Because no other professional can match your skill. What you have learned with your patients, under the supervision of your mentors, your teachers and faculty, and your management of your institution, that is going to give you the guidelines and give you the courage to practice the profession in your professional life. The confidence you develop comes only when you sincerely, committedly complete your responsibility towards your patients. And that is the responsibility towards your society, for which these regulations have come through. The course has been revised number of times. Initially it started with 6 months diploma, it became 1 year course in 60s, then in 62 it became 2 years course, 68 it became 3 years course, then in 71 it became 3 years graduation. The diploma continues till 1994. Some diplomas were 3 years, some diplomas were 3.5 years, but they were in demand so much that they were equated as a foreign graduate. The graduation at foreign level also. And the equivalence certificates were issued by the institution and the ministry board. So the credential evaluation for migrating abroad was much easier. But it was not regulated throughout the country. There were only some few fortunate states where these equivalent certificates were being given. But now you are fortunate enough that you have a regulatory body where you have a throughout India, pan-India equal credential system, which will give you the credits, but that will ensure you that you learn to earn the credits. Until unless you learn, this is a competency-based curriculum which has been released in 2024. And this curriculum means that your faculty and your management is making sure that you learn the minimum standards of a profession. But for that, they are developing the infrastructure, the faculty updates, everything the university needs to do, and they are doing the same. Now this course has become a 5-year course. Because this is a hands-on course, a patient-oriented course, you need to work on the patients, you need to have a clinical material for your experience as well as for your research. So at the research level, when you go for the specialization, you incline towards the specialty in your graduation, and for post-graduation studies, you choose some specialization for which you require a number of clinical material. And that clinical material is your patient, and you should be thankful from your core of your heart to your patients only, which give you the opportunity to learn, which give you the opportunity to apply the skills which have been taught to you by your teachers. So these values have to be inculcated into yourself once you pass out from the course. And your mentors are qualified enough to imbibe these values into you. You know, there was a conference in 1994, the Trauma Victim Rehabilitation Conference, which was organized by Indian Medical Association. So there was an important thing happening. One neurologist from the USA, Professor Eric Holmes, she was the president of the Society for Rehabilitation of Trauma Victims. And we had a conference, a world conference of International Trauma Victim Conference, Rehabilitation Conference, in which she said from the stage that physiotherapists are the only professionals who have the healing skills. they have the healing hands. And her lecture, this address was published in the journal. So this gives not only an opportunity to us, it is a great responsibility also. That you have to be competent enough to satisfy a patient and cure or heal your patient. That is why being a hands-on course, initially from 6 months course, now it has become a complete 5-year course, where the clinical exposure has been given a complete dedicated time space for your experience you gain on patients, on clinical material, so that you learn in the clinical settings itself. And it has become mandatory to have hospital setups in all the institutions of a required strength and required specialization, so that the multi-speciality experiences which you will get, that will give you some inclination towards your interest in working for some special specialty. So that is the National Commission for Allied and Healthcare Professions, which was passed. The Act was passed in 21, and it has been implemented now from 26, the 7th session. The course has become a 5-year course with 1 year complete internship. And those internship guidelines have already been devised. The regulations are yet to come very soon. As a member of Central Professional Council and National Commission for Allied and Healthcare Profession, I would request you to go through the Act completely. I think the legal and ethical portion is also a part of the curriculum. So include that portion to let the students know what are their rights and what are their responsibilities for becoming a successful physiotherapy profession. And that will give you an insight that how serious and how important physiotherapy profession is, and how you can contribute best towards your society. Because if you serve the society with complete commitment and dedication, that will give you a standing in the society itself. Your professional values will come to know, and you will find new innovative methods. How you can innovate yourself into a new specialty, how you can innovate a new device, how you can innovate a new assistive thing for your patients. Right? All these things will now be documented very well, which was not the picture till 2021. So now you will not have any difficulty in getting your credits evaluated internationally. You will get a complete normalized nomenclature throughout the country, a unified curriculum throughout the country. The task force has given its complete dedicated efforts in devising the new curriculum, which has a very bonded curriculum. You know, all courses, they have 32 weeks, 30 weeks per year. But physiotherapy course, because of its requirement, it has a 36 weeks in a year of academic curriculum. We are coming to the national standards because in other countries, it is up to 46 weeks per year. So we are gradually approaching that, but our demographic profile, our needs of the society will definitely be part of it. So this important event in your life, you are at the transition border. So go through that act, see what is new into the curriculum, because you would be passing out early than the 2031. In 2031, the first batch will come out. So the first batch will have a complete professional registration. The registrations are going to be started very soon, and as a professional, all professionals need to get registered, and that registration will give you the right for autonomous and dignified practice throughout the country. Right now, we do not have throughout the country regulations. Till 2021, there were only 8 state councils which were existing throughout India. But now, pan India, you have a regulation. Wherever you want to migrate, you will migrate to the same credentials without any addition or deletion. So that is a very important and new development in the field of physiotherapy medicine. Right? As sir said, becoming a doctor is a great responsibility. Right? Because the literary meaning of the doctor is to preach. But to preach and to treat both, that is an added responsibility for a healthcare professional. So that puts you in a place which is very proud for yourself, very statured in the eyes of the society, and very honored in an educated society. And you have to fulfill all the requirements, all the responsibilities which society and your profession gives for the mankind. For that, you have to imbibe the human values into you. Be sensitive to the patient's need. Be humble to the patient. Only then you would be able to know complete history about the patient. So these human values are also to be imbibed by your faculty into you. Your university is doing wonderful job for making compliances towards the National Commission, and I think that by next year you will find the complete departmental turnover. Right? So I congratulate you for becoming the batch which is seeing the transition, and congratulate you to being a part of the university. You are coming out of an institution which will give you the best. I congratulate the whole organizing committee, the faculty. Thank you much, Chancellor sir, Registrar and Dean sir, for making me a part of this important event. So thank you very much.
these all we have to advise the patient. Policy support. Advocating for policies that promote inclusive in sports at all levels. They are able to do some sports and they can participate in competitions, so we can help them. What all policies they can come under? So, for example, any disability, any autistic cases also, we can make them group things, and we can. There are many policies in the government, so accordingly we can train them also. So they can participate in state level, national level, international level programs, competitions. So training programs. Implementing training for coaches to effectively support and empower adaptive learning. So we also have to support the coaches and tell them what are they capable of and how we can bring them. So this is how we can help it. So the types of adaptive sports for stroke rehabilitation. First one is aquatic therapy, swimming, which reduces the joint impact and improves your cardiovascular. Seated volleyball, so enhances coordination and upper body strength. So this also we can support. So wheelchair tennis or basketball, it helps to boost the endurance and agility. Adaptive yoga or tai chi, it helps to promote relaxation, balance and flexibility. So adaptive biking, riding a bicycle is a great form of cardio that can benefit your overall health after having a stroke. Tri-wheel bicycles assist those with limited balance. High-back bicycle seats help maintain an upright position. Tandem bicycles allow shared activity for individuals with limited movement or balance. Steering dampers enhance stability by limiting handlebar. So we have to choose which sport will be adaptive for the particular patient, and we have to encourage them and we have to rehabilitate accordingly. So adaptive bowling, played in a wheelchair or in standing with bowling a ball ramp. If you struggle with arm movements, strength, trunk and stability. Use a grip bowling ball that has a retractable handle for easier grip on the ball. Additionally, you can use a ball pusher or push the ball on the ground for people that may have limited shoulder. So according to the patient, we are going to decide what type of sport we are going to give. So there are few case studies here. The study assesses the impact of an adaptive physical activity program on mobility and quality of life in chronic stroke patients. 20 participants are engaged in a 2-month exercise regimen focused on mobility. Results showed significant improvements in work balance scale, 6-minute walk distances, and short physical performance battery scores, Barthel index scores. While Lawton scores remain unchanged, both geriatric depression scale and stroke impact scale scores improve, indicating that APA enhances gait, balance, and some daily living activities as well as stroke-specific outcomes related to QOL. Adaptive physical activity for stroke and early stage randomized controlled trial in the US. One more study, I can give it to you. You can also go through that. So now coming to the structured rehabilitation plan, focusing on a stroke patient to participate in an adaptive sports. So in 2024 study published in American Stroke Association journal compared high intensity interval training with moderate intensity continuous training for stroke survivors. The research demonstrated that HIIT produced superior gains in cardiovascular fitness and endurance measured by VO2 peak. Additionally, HIIT helped maintain fitness longer, reduce the risk of recurrent stroke. So, we have to decide what type of exercise intensity we are going to give the patient, and slowly we gradually improve the intensity also. So, this makes HIIT a viable approach to prepare stroke patients for endurance-based adaptive sports such as wheelchair racing or rowing. Nowadays, we come across many Olympic, Paralympics also we see. You can see many challenging patients. So, what are the few exercises? Warm up and flexibility exercises, stretching. Anybody want to do the exercises? Who is ready to learn? Exercise. I can join. No, if you allow, I can. Any student?
Students please come up. Some students please come up.
You can demonstrate the exercise.
Any model?
अरे कोई एक आ जाओ ना आप आ जाओ. इधर आप आ जाओ. अरे आ जाओ.
With the goal of stretching and dynamic movements to be given us, it improves the flexibility and helps in reducing the stiffness, especially in spastic or weak areas. This prevents injuries during the sports participation. Shoulder release. How do you teach the patient? But they can do practices. Why no one came forward? Shoulder rolls. So we have to give this much stretches to the patient. You should be strong enough to do the exercise, right? You have to. It's okay. They won't be able to do that. We'll be supporting them. So it depends on the patient also, whether it's going to be active or passive stretches working. And for the lower limbs, leg swing. These all are easy exercises just for a warm up for them to prepare for the exercise pattern. How will you do the hamstring? Yeah.
Go ahead.
So they are in lying position, support them accordingly, or either in 60s or in standing according to the patient's the adaptability which they are going to So pecs and lat stretches, pectoral stretches. Anyone else can demonstrate from there? Pectoral stretch, pec stretch.
Do it. No, देखना चाहते हैं.
You have to support your head. Place your hand here, not here. How do you get the stretch? So when we learn, we have to learn the posture also properly. How we have to perform the movement. This is our role to the patient. We have to teach the patient that we are going to teach them a proper way of exercise. There are many professionals also trying to overtake our profession. That we all know we are struggling and still we are, For example, trainers, they also say we know exercises, we know how to do. Only 8 major muscles they know, but they'll say they know everything and they'll teach all the exercises. But we only know about each and every muscle and we can only teach the patient how to maintain the posture and do the exercise. So we have to be very responsible in it while teaching the patient. So we should know. So upper body. So we can teach the seated push-ups like that. So you can see that you can sit. You can sit. The patient will be on the wheelchair, right? So we can ask the patient to do like this, so their shoulder will get strengthened. So they can So resistant band exercise also you all will be knowing, right? Exercise that we done. What is resistant band? Yeah, there is. So we have to first start with basic level and then we have to move on to the next. So, options. What? Near the wall can. Yeah. maintain and all, you have to check. So coming to lower body, mini squats. Mini squats, how do you do? Will the patient be able to do the whole squat? It's very difficult for them. So according to them, we are going to manage. First, we can start with sit to stand. So gradually, you can then make them do it without support. You can make them do like this, and then we gradually increase the level to them reaching the ground. So heel raise to build ankle strength and stability. How all you give heel raise? There are various types of exercises in heel raise. You can do it in sitting. Again, it depends upon the patient. That's why it's a adaptive exercises. So you can do in sitting, you can do in standing, you can do while walking also. You can. So gradually we have to progress the exercise. Step up on a low platform for stair negotiation practice. So step up, step down. First we will start with the low raise steps, and then gradually the height should be increased. So core exercises. Core exercises. So how you will improve the core of the patient? They will be already feeling difficult in walking or standing and all. So how will you start with it? The patient is on the wheelchair, how will you start? So you can twist and you can start with this. So you can engage the core first. If your patient is in lying, you can start with pelvic tilt, then pelvic lift, which is pelvic tilt, we are going to activate the muscle. Now pelvic lift will be giving the mobility. Then gradually move to pelvic bridging, which is going to strengthen the muscle. So gradually we have to plan the exercise for it. So plan. Plank initially is very difficult for them. So gradually we have to increase. First with knee support. So gradually we have to improve our other muscles and we have to move on to the plank. So it helps to improve the muscle function in affected limbs and core to enhance movement control, making them better equipped for activities like adaptive rowing or surfing. So balance and coordination training. Who all attend? OP is there here. OP is there in your college. How you get patients experience, clinical experience? Do you visit your OP? How many patients you see a day? No answer. I'm not going to ask any questions, just asking. Do you visit your outpatient department? Why? Exposure is very important to grow in our profession.
You are in which year?
Which year? Second year. Second year. That's right.
Because third years are all posted in the different hospitals. So definitely they are doing. Anybody from third year who are posted in the hospitals and did some OPDs? थर्ड ईयर के बच्चे हाथ उठाओ ना, पाओ ना, थोड़ा बोलो OPDs के बारे में बोलो.
Good. What type of patients you are observing?
अब क्या देखे हो हॉस्पिटल में, थोड़ा बताओ.
What type of patients you see a patient? How do you engage with your patients? Just share this for your clients.
जनरली हॉस्पिटल्स और क्लिनिक्स के अंदर मतलब आपको लो बैक पेशेंट, मतलब जो लो बैक के पेन होंगे ना, उसके पेशेंट ज्यादा देखने को मिलेंगे, नी पेन के मिलेंगे, और आजकल तो मतलब पैरालिसिस भी कॉमन हो गया है हर पेशेंट के अंदर. किसी ना किसी में आ ही जाता है, क्योंकि टेंशन, बीपी वगैरह सबके आजकल बनती रहती है, और सीपी के पेशेंट्स भी बहुत दिखेंगे, बट जनरल पेशेंट आपको दिखेंगे आपके बैक पेन के, नी पेन के और सर्वाइकल पेन के.
Good. Looking forward to it. This is where we all are lagging. You should not lag in your confidence. That's very important in this profession. Single leg stands also can try. So first, for in-stroke patients, while weight shifting exercises, we can start with back support. If the patient is here, then we can do the back support slowly. We can give a Swiss ball. When they are in the bed, we can support them with the Swiss ball for the sitting balance. So gradually we can move the Swiss ball also. So this will slowly increase the balance by weight shifting in sitting position. So then gradually we can move to single leg stance. That also support will be given slowly. We reduce the support. Then coordination drills. Tossing a ball against a wall or playing and catching. So we can engage, if it's a rehabilitation center, we can engage them. Engage the other patient, 2-3 patients also to engage, and then we can improve their coordination skills also. So gait training. Gait training, we know, slow gradually. Types of gait training, and we will be having parents also. So gait training is also improving accordingly. Our profession, when we were all studying, we had nothing. We didn't have professors also. We all mostly the seniors all are self-made. We all learned through our experiences. This is how we all learned. But for you all, you have everything. You have everything. You have till professors you have. This is how was not a college 25 years back. That's how all the facilities are there in every college. You all have to utilize it. This is your profession. This is going to be your life. So accordingly, you have to plan yourself. So never lag in your profession. Because that mistake you do, it's the life of the patient. So learn well. Whatever you learn, you put your full self, 100% self, and you learn. You can put 200% also. So coming to cardiovascular endurance exercises, we can encourage them with static cycling, arm ergometers, treadmill exercises, and swimming also. So it helps to build a standard to participate in sports for a longer duration. So where we are going here, cardiovascular endurance exercises is going to help them to maintain their endurance level, so they can participate in sports for a longer time. It's going to be their lifetime. So functional mobility drills. Obstacle courses. It helps the patients to practice navigating uneven terrain, simulating real life or sports conditions. And wheelchair mobility drills for those using wheelchairs, practicing rapid turns and controlled stops, improving agility and sport fitness. Goal of the functional mobility drill is to enhance the functional independence during the sports participation. The cognitive and reaction time exercises. So in this we give them multiple task activities. And nowadays we have moved on to VR rehab also, which is really helping a lot to engage the patient every day. Every day they feel they are doing the same exercise. They don't feel comfortable. They don't feel to be engaged with exercise. So we have to go for the exercise session. Really not at all happy. So they won't be able to, they feel difficult to do the exercise also because it might be boring. When we give it through the VR games, really it's going to, they are really engaged and they are getting good results also. Then coming to the cool down phase, general stretches and slow breathing exercises and mindfulness or meditation. So challenges in implementing adaptive sports. It's the accessibility of the venues and specialized equipment, training space for patients, high cost of equipment, funding or sponsorship issues is also there. Lack of awareness. We are in the place to give awareness for that. Training and coaching limitations is also there because many coaches get fatigued to train the patient. Psychological health barriers are very important and inconsistent policy frameworks. These are the challenges for us. So what we are trying to conclude is holistic recovery. Because adaptive sports provide a well-rounded approach targeting physical, psychological, and social aspects of rehabilitation. Complementary approach. They work alongside conventional therapies to promote better outcomes. Empowering stroke survivors. This is very important. By fostering independence, building confidence in them, and motivation and adaptive sports enhance their quality. Engaging lifelong physical activity reduces the risk of recurrent strokes and secondary conditions. I've seen a patient who had a stroke 4 times. 2019, she had the first stroke, and then because repeatedly I was saying the patient, because it was a home visit, we couldn't give them a proper psychological support. If they were in a rehab center, we can give a psychological support. But they were not ready to move to rehab because they were in a rehab center for a long time. This is how the patient used to get tense and the science would happen. In the 4th stroke, she lost her eyes. Now we are making her still. So very important is the teamwork for a stroke patient is very important. So always I've taken much time.
Good morning everyone. I am Sarika Agarwal. And I am Kashish Rathod from VPT second year. And we would like to thank you, ma'am. That was truly an enriching session. There are sessions that give us information, and there are that make us pause, reflect, and look at our profession from a different perspective. I think the experience later today, I'm sure many of us leaving this session with not just notes in our notebooks, but ideas in our minds. Let's give Dr. Geriatric a warm round of applause for an insightful session. Every contribution to a conference like this deserves to be acknowledged. So we would now like to take a moment to express our appreciation formally. May I request Honorable Vice Chancellor Sir, Professor Viswajoy Chatterjee to kindly come forward for the presentation of Dr. Geriatric. Thank you, ma'am. It has been a privilege.
I have for the general public, I had a question to ask you, madam. Actually, like, how much is this like sports that you said for the stroke patients available in India? How much is it available? No, I'm not talking about exercise, rehabilitation. Those things are good, but those get a little boring at times. If there are sports facilities which can be done outdoor, then I believe the stroke patients will be more benefited.
Government has their sports authority, right? There itself they are training.
So
there are proper coaches, yes.
As a general public, where I should
we have to educate them.
Because my mother is a stroke patient, so I am asking from my point of view.
In your case, we have to search for it.
Okay.
So each stroke patient has its different ability and lacking of the daily activities or something. So it is the personalized or individualized setups where at home also we can set up such kind of activities where the physiotherapists or psychosocial workers, they can engage the patient at home itself. So there are different protocols for that. For physiotherapy, the clinical protocols which will make the muscles more strengthful, make the muscle more coordinated, and the neural stimulation. That is a part of physiotherapy. Rehabilitation is step, and rehabilitation is not physiotherapy, and physiotherapy is a part of rehabilitation. Rehabilitation starts from the consultant, starts from the physician, and goes down to the psychosocial level. So this is a comprehensive process. And individualized facilities are available. Only your healthcare professional has to be knowledgeable about it. Thank you.
As a team, we need occupational therapists, social workers, psychologists, counseling psychologists, psychiatrists.
Every part, because this is a coordinated work, and each and every person is responsible for evaluation of physical, mental, and social strength of the patient and convey it to the responsive person.
I really believe if this can be done, it will be a great thing because
it's happening.
add something here, sir. We have our students are being posted. Other than that, we have a member in our MS University that has studied. Injury patients were being treated. So we had made a particular room in which we had basketball nets attached. Initially, we did more training. More training is done. Entire physiotherapy is completed. Occupation therapy rounds are completed. And then we used to have sessions with them 4 o'clock to 5 o'clock in the evening. They used to play basketball with us on their wheelchairs. So we used to shift them on their wheelchairs also. It also requires training. You've seen the kind of wheelchairs ma'am has shown. So even these kind of avenues can be started by you as a niche in your own clinics or setups where people don't find, like sir has a patient in his own clinic, in his own home. He needs a clinic around, but we don't have such clinics. So you can have such niche setups in your clinics around. Thank you.
I will request all our physiotherapy teachers to kindly suggest us that what sort of such new things can be done within the university. There are certain things we can do within the university, but I will have to know now. I don't belong to your profession, so I don't know that. So if you kindly guide us, we can definitely come up with some innovative things within our university itself.
So it is like curricular now. The modern curriculum has included the infrastructure which is required for a basic physiotherapy and rehabilitation. Hydrotherapy, exercise therapy, or basic everything has been specialized in curriculum. So you can develop in the university. Your university has a wonderful facility.
Definitely develop, but the teachers will have to do it. Teachers will have to guide. Thank you.
Yeah, I'm taking the opportunity of 1 minute for that. I'm heading the clinical department of WPOF University. So what we are doing to our patients, we use the tele-rehabilitation also. At the same time, we are working on task-oriented training by using very normal and available things in our home. Just take a water bottle and a cup of empty cup, and we can use that in the mechanical functional activities to avoid going like just giving a co-flexion and extension pain. So just we can add like this kind of activities, and some people can afford a little bit. Yes, of course, it's not much of expensive. We can have VR holders are there available. Everybody has smartphones, so we introduce breathing exercises, which is simulation. The old people they also enjoy that while doing the breathing exercises, because breathing exercise is very important in endurance part of the stroke rehabilitation. And many physios also fail to do this. So we encourage these things either with the tele-rehabilitation as well as with the semi-supervised and observation. So we are dealing with that. So very soon we are going to cover entire Punjab rural villages also, connecting with that one. And we have got one PhD awarded in the tele-rehabilitation also. This is one thing which we can explore in future.
Sir has asked a very valid question. As a physio, we all know what to do. We all decided what to do. What should sir do at home for his mother? That's the question. Question is not what we can do. We all are medically trained. What is he going to do for his mother? He can see video, Google, then he does everything wrong. Who will show him the correct thing? And what is the correct thing? Is the positioning of the patient. You can be only 1 hour with the patient as a physio. You're not a god. You're just a human. 1 घंटा आप पेशेंट को दे सकते हो, 23 घंटा उसकी फैमिली है, उसकी फैमिली को मालूम होना चाहिए कि इस पेशेंट की लिमिटेशन क्या है और ये क्या कर सकता है. You will get feedback from the sir. So whoever is in the 3rd year, please talk to sir, tell him what his mother can do and how you can help him. That's where the physio. We can't come every time to you guys. So you have to come up and tell sir मैं 3rd year में हूँ, मुझे आपकी मदद को एक बार चेक करने दो. हमारे प्रोफेसर के साथ जाएंगे and we will guide you what to do. He has come himself and asked you कि मुझे पता होना चाहिए कि मैं क्या कर रहा हूँ मदर के साथ. मैं बास्केटबॉल तो उसको खिला नहीं सकता, बट मैं उसको बेड टू बाथरूम कैसे लेके जाऊँ ताकि उसका एंकल्स पेन ना हो, उनका नी इंजरी ना हो, राइट, उनके कॉन्ट्रैक्चर्स एंड टाइटनेस डेवलपमेंट ना हो, कैसे वो बैठे, कैसे वो उठे. That's the main scheme where we conquer everything. So that's the simple suggestion for all the students. अगर chance मिले तो सर को मिलो, the way he has come yesterday, since yesterday is with us, right? बहुत कम VCs, मुश्किल से कोई VC हमारे पास ऐसे आते हैं जो बैठते हैं डिस्कस करते हैं. So you have an opportunity and wish you all the best. Sir is here. अब छोड़ना मत, इनको पकड़ के रखो VC.
I would like to add, as I understood there is no OP in the university, you can develop your own OP with the faculty and the students you have. There are so many problems existing in yeah, and they can do a survey, get what all the problems which are existing in the staff family or the students family, and encourage them to come to the OPD. That itself gets a lot of OPD. And as sir was saying, we can encourage not sports, we can encourage your mother with all aerial and functional activities. How she can dress up herself, how she can home herself, how she can lead independently. That guidance definitely will help your mother. And that is what students have. Going to the visit, how to modify the things in the home so that the patient can feel comfortable.
As I came from Chennai, I want to leave something for the students. For you, so someone can distribute it. I have a bookmarker for you.
So that time we have put the cameras all over, and we have even seen physiological stress in the neonatal ICU on newborns. So those time we have done the movement analysis for the infants.
Usually patient used to be inside the incubator. Light therapy also will be going on over there. सब बच्चे को ही जॉन्डिस होने का चांसेस है और रिस्क स्मॉल बेबी एनी टाइम और विदिन फ्यू सेकंड अगर आपने कुछ गड़बड़ किया तो पेशेंट पास हो गया. So we have to take optimum care in this case. So management of neonatal ICU is one of the most important aspects of the critical care practiced by physical therapists. Developed in the 1950s and 60s by pediatricians to provide better temperature support, isolation, specialized feeding, and access to specialized resources. Infants are taken care in incubator or open ward. Airway complications can generally be avoided by appropriate attention and timely intervention by the physical therapist and other caregivers. Public access is very much restricted or limited to avoid infection. आपको विजिट के लिए वहाँ पे अलाउ नहीं है, वहाँ पे आप जा नहीं सकते. Only mother can enter inside the ICUs, neonatal ICUs, and with optimum care. अलग से ड्रेस करना होता है, मास्क लगाना है, शॉक प्रिकॉशंस लेकर अंदर जाना है, बेबी को फीड देने के लिए. Airway complications can generally be avoided by appropriate attention and timely intervention by physical therapists and other caregivers. Public access is limited. Visitors, that is already discussed. Signs of potential distress or deviation from expected findings. हम लोग जाके क्या और देखेंगे, expected findings क्या होना चाहिए. Asymmetrical chest movements, diminished breath sounds, seesaw respirations, grunting, nasal flaring, retractions, deep sigh, tachypnea, respiration more than 60 per minute, persistent irregular breathing, excessive mucus, persistent fine ripples, straight. A lot of complications will be, but you can find over there. और common जो प्रॉब्लम है, चलो ये इतना डिस्कस करने का टाइम नहीं है. Congenital abnormality जो लेके पेशेंट एडमिट होता है वहाँ, that is important. Laryngomalacia, tracheomalacia, tracheoesophageal fistula, trachea and esophagus. आपको पता है before birth the two tubes should be separated. कभी-कभी ऐसा होता है रह जाता है. 8 दिन जैसे ऐसा रह जाता है कुछ प्रॉब्लम्स. ठीक है, तो दैट जैसे सेपरेशन नहीं हुआ, एक तो इमीडिएटली डिलीवरी पोस्टनाटल कंडीशन में इसको सर्जरी किया जाता है, सेपरेट किया जाता है. दैट neonate should be inside the neonatal ICU. Tetralogy of Fallot, आप लोग जानते हो, पढ़ लेना थोड़ा सा. tetralogy of Fallot पढ़ना जरूरी है बच्चों को. VSD, ASD, PDA, patent ductus arteriosus. Ductus arteriosus तो ऐसे जैसे tracheoesophageal fistula ऐसे बॉडी है, कनेक्शन है जो जस्ट बिफोर बार्थ को क्लोज हो जाता है, लेकिन वो कभी-कभी रह जाता है. क्वार्टेशन ऑफ aorta में एक है जो जिसकी वजह से ब्लड और ऑक्सीजन जो प्रॉपर प्यूरिफिकेशन होना चाहिए वो नहीं होता है. ठीक हो, हम थोड़ा सा पहले भी डिस्कस किया है. और babies who need to go to this unit, they born prematurely, difficulties occurring during their deliveries. डिलीवरी के टाइम कुछ ना कुछ कॉम्प्लिकेशंस की वजह से हो जाता है. ठीक है, जैसे फोर्सफुल बात में असिस्टेड बात में प्रॉब्लम्स हो गया है और उसने आईसीयू से भेज दिया जाता है. दे शुड साइन ऑफ ए प्रॉब्लम इन लाइफ और वहां पे जाना है. यहाँ पे मैनेजमेंट बहुत ही टफ है. सो यू हैव टू टेक ऑप्टिमम केयर and you have to take for the precautions for yourself also. अपना head wash कैसे होना है, that has to be done practical exposure होगा तो पता चलेगा. Now respiratory क्या कैसे हम करेंगे, क्या करेंगे. जैसे partial drainage is important, हम बोलते हैं partial drainage करना है, कैसे करना है, that is very important. Humidification and aerosol therapy, जैसे
मेडिसिन के बारे में हम इतना बात नहीं करेंगे क्योंकि हमारा रिस्पांसिबिलिटी नहीं है देने का, लेकिन एरोसोल थेरेपी के टाइम विद द कंसल्टेशन ऑफ expert medical professionals we can discuss with them and we can give the जैसे लिखा है यहाँ पे बीटा फ्रूट एड्रेनर्जिक एगोनिस्ट हम देते हैं, जैसे सल्बुटामोल मेडिकेशन मिल जाता है, दैट कैन बी दैट सेक्शन। रिएवरेज मैनेजमेंट के लिए यहाँ पे आप देखो पार्ट क्या क्या इसमें होता है, एक बार ये प्रैक्टिकली मैं कुछ लेके आया हूँ, मैं बताना चाहूँगा। सेक्शन क्या बेटा आप लोग बाद में देखना नहीं, यहाँ पे आगे के क्लास में दूसरे दिखा देता हूँ। अच्छा, सेक्शन के लिए पेडियाट्रिक सेक्शन क्या कहता है, इन इंडिया इट इज वेरी डिफिकल्ट टू गेट, तो पेडियाट्रिक सेक्शन के लिए हम इंडिया जुगाड़ करते हैं। दिस इज सेक्शन के तहत ये बहुत स्मॉल मिला है, लेकिन यार ये मिला आपके सेक्शन प्रेशर कंट्रोल के लिए यहाँ पे साइड पे कोड है, इसको हम बंद करके रख सकते हैं और अपने हाथों से इसको कंट्रोल करना है, ठीक है। When the suction pressure will be applied, that has to be closed by your thumb, ठीक है, और जब जरूरत नहीं है आपको इसको छोड़ दो, प्रेशर रिलीज कर दो, ठीक है। अगर इतना स्मॉल नहीं मिले तो हम क्या करते हैं, इंडियन जुगाड़ सक्शन कैपेसिटर की जगह में हम करते हैं क्या, फीडिंग ट्यूब हम अप्लाई कर सकते हैं, ठीक है। लेकिन फीडिंग ट्यूब में कभी-कभी साइड वाला पोर्ट नहीं होता है, तो दैट इज नॉट द राइट वन। साइड वाला पोर्ट में ओपनिंग्स होना जरूरी है। फॉर्चूनेटली मैं मुझे मिल गया था, ठीक है, लेकिन ऑलवेज इट इज वेरी डिफिकल्ट। अच्छा, दैट वाज फॉर न्यूरोलॉजिकल पेशेंट और एडल्ट के लिए। एडल्ट के लिए ये इससे कंट्रोल वाला होता है। ये एक्चुअली पीडियाट्रिक के लिए, वो न्यूरोलॉजिकल के लिए है, पीडियाट्रिक के लिए सेम टाइप है। अच्छा, आप लोग एम्बू बैग देखा है, ठीक है, ये एडल्ट के लिए, चिल्ड्रन के लिए, ये पीडियाट्रिक पेशेंट के लिए, ठीक है, 5 to 10 years लाइक दिस। इसमें काफी फ्लोट है, ठीक है, ऑक्सीजन कनेक्टर है, ठीक है, यहाँ पे क्लोज करने के लिए आप ये देखो, और ये एडल्ट के ग्रुप में भी लेके आए, थैंक यू। एडल्ट के इसका मेजरमेंट है, हम 250 ml से लेके 1000 ml तक, दिस इज क्लियरली एडल्ट, ओके। और इसका पार्ट क्या है,
डॉक्टर जी, मैं एक चीज इंटरप्ट करना चाहूंगा। हां, इफ यू एक्सप्लेन व्हाट इज एम्बू, हाउ मेनी ऑफ यू नो एम्बू, व्हाई इट इज कॉल्ड एम्बू?
वो मैं पूछा था।
Any students knows about the 4th year student who have undergone the cardiopulmonary physiotherapy sessions? So this is heart structure. It is ambu. Have you seen the ambu written on the papers? Capital letters. What is the title? This is auto-inflated manual breathing unit. So you need not inflate this after one session, and patient, you need not wait for the flow. That is why it is used in resuscitation. All these equipments which are there, Dr. Sarkar is showing, you would come to know all these are given in your course, but you need to study them practically and need to see the application. Sterility is maintained, how these are touched, how these are used, what should be the pressure, what used in pediatric patients and adult patients, how the French size is calculated, what is the correlational patterns.
Lot of factors are there. Lot of factors are there that has to be taken care. That's why before entering inside the ICUs, you need to
First, we take a complete day workshop.
complete day workshop.
I used to
class. So these are the okay. In future, hope that अच्छा आईसीयू में जो गया जाने के समय या आईसीयू के अंदर जाके क्या टेंशन हो रहा था? कभी कभी ऐसा लगता है मेरा जान ही निकल जाएगा, ठीक है ना? पेशेंट का जान क्या है, अपना जान ही निकल जाएगा। इसलिए और एक बात है, बिफोर गोइंग टू न्यूनेटल आईसीयू you need to go to adult ICU first. Okay? Or before starting of any of your technique, आप साथ में just entry करना है, 2-3 घंटे रहेंगे, वापस आना है. Then you will be able to habituate inside the ICU. एक एग्जांपल दे रहा हूँ सर, आप नाम नहीं बताऊंगा, one of the famous PRN डॉक्टर, फिजिकल मेडिसिन का डॉक्टर, वो वर्ल्ड फेमस बोलते देखो, वो चौड़ा होकर हमारे ऊपर काफी दादागिरी किया है. आपको पता है किसकी बारे में बोल रहा हूं मैं. तो एक बार बोल रहा है तुम्हारे साथ आईसीयू जाते, ठीक है, मेन आईसीयू जो हम बोलते थे, चलिए ठीक है सर 2 बजे के बाद चलिए चलते हैं आईसीयू. जो पेशेंट को फर्स्ट करना था उसके बाद किया है, उसको कुछ कॉम्प्लिकेशन शुरू हो गया, मतलब शुरू जस्ट एंट्री किया है बेड के पास और रेसिडेंट डॉक्टर्स भागा आए हैं, इसका कुछ कॉम्प्लिकेशंस हो गया है, तो भी हेल्प करो, ऐसे मैं भी साथ में उनको हेल्प कर रहा हूं. पेशेंट को रिवाइव किया गया, ठीक है. नेक्स्ट पेशेंट गया है, मैं शुरू किया, सक्शन करना शुरू किया, उसका कुछ शुरू हो गया है, तो 2 पेशेंट ऐसा हो गया. उसके बाद पूरा कहीं मैं बाहर जा रहा हूं, ठीक है, आप लोग वेरी गुड वर्क, बहुत अच्छा काम कर रहे हो, मैं बाहर जा रहा हूं. वो सोचता है आईसीयू में ऐसे बहुत अच्छा ऐसे ये कोई बात ही नहीं. तो ऐसा होता है, किसी के साथ हो सकता है, दैट इज नॉट अनयूजुअल. ओके, सो वी कैन प्रोसीड फर्दर. One of the patients, टेक्निक हम क्या करते हैं, पोजीशनिंग इज वेरी इंपॉर्टेंट. कैसे पोजीशन होना चाहिए, परकशन, वाइब्रेशन, टेंटिंग. टेंटिंग क्या है, हम जब क्लैपिंग करते हैं, ठीक है, उसको टेंटिंग अच्छा करते हैं, 3 फिंगर से होना चाहिए. अच्छा 3 फिंगर्स में आपको प्रॉब्लम हो रहा है, व्हाट इज दिस फेस मास्क, इतना छोटा कहां लगेगा, ये पेडियाट्रिक फेस मास्क. सो इसके हेल्प से करते हैं, हम ऐसे पकड़ना है, ऐसे जहां पे कंफर्टेबल हो, और वहां पे रिस्ट मूवमेंट भी होना चाहिए, एल्बो मूवमेंट कभी नहीं होना चाहिए, यहाँ से शोल्डर का भी नहीं होना चाहिए, सेम रिस्ट मूवमेंट होगा. आप दूसरा जगह जब वाइब्रेशन करेंगे तो सेम शोल्डर का मूवमेंट होगा, वाइब्रेशन यहाँ से आएगा, तब यहाँ से कोई वाइब्रेशन नहीं होगा. सो दैट हैज टू बी टेकन केयर वेरी मच. अच्छा सक्शन इक्विपमेंट्स, सक्शन के टाइम क्या क्या कॉम्प्लिकेशंस हो सकते हैं. नासोफेरिंजियल एंड एटीट्यूड सक्शन हेल्प टू मिनिमाइज एस्पिरेशन, प्रिवेंट क्रिटिक ऑक्लूजन, क्रिटिक एंडोट्रैकियल ट्यूब ऑक्लूजन एंड लोअर द एयरवे. कॉम्प्लिकेशंस ऑफ ट्रैकियल सक्शनिंग इन इन्फेंट्स आर एज फॉलोज. क्या हो सकते हैं, नंबर 1 इन्फेक्शन तो होने का चांसेस बहुत है. और इंडिया में इन्फेक्शन नहीं हुआ तो क्या पेशेंट क्या आईसीयू के मतलब इन्फेक्शन होगा, आईसीयू में भेजा तो इन्फेक्शन होगा 100%. अगर यूरोपियन कंट्री में एक पेशेंट का इन्फेक्शन हो रहा तो दैट आईसीयू हैज टू बी क्लोज्ड फॉर 1 वीक. वो पूरा स्टेरिलाइज करके फिर शुरू करना. लेकिन हमारा वो ठीक है, आप एंटीबायोटिक दे देंगे, बहुत एंटीबायोटिक अवेलेबल है हमारे कंट्री में, और हम कंपनी का बेनिफिट बढ़ाएंगे. नेक्स्ट एक्सीडेंटल एक्सट्यूबेशन. एक्सीडेंटल एक्सट्यूबेशन बच्चे का तो बहुत होने का चांस है, एडल्ट का भी बहुत होता है. अगर पेशेंट इंट्यूबेशन के बाद उसका मूवमेंट, एक्स्ट्रा मूवमेंट बॉडी में काफी है तो एक्सट्यूबेशन होने का चांसेस बहुत है. एटेलेक्टेसिस, लंग कोलैप्स हो रहा है, ब्लॉक हो रहा है, ठीक है. ब्लड प्रेशर स्टेबिलिटी हमेशा चांसेस है. इंक्रीज आईसीपी इंक्रीज उसी का ही होगा, किसी का ही हो सकता है, लेकिन हेड इंजरी पेशेंट के चांसेस बहुत है. इसीलिए आईसीपी मेजरिंग इंस्ट्रूमेंट होता है जिसमें से पता चलता है कितना चल रहा है, ठीक है. वो कंट्रोल करना, देखना बहुत ही जरूरी है. सेरेब्रल वासोडाइलेटेशन, सेरेब्रल हाइपोक्सिमिया, हाइपरकैप्निया, ब्राडिकार्डिया, न्यूरोथोरैक्स, these people are that a number of problems can arise. जो भी आप सोच सकते हो क्या क्या हो सकते हैं, everything can be possible. Suction equipment क्या है? Suction equipments थोड़ा बहुत जैसे DD traps भी है, लेकिन mechanical suction equipments is very very important. और उसमें control panel होना जरूरी है. Oral and pharyngeal suction of infant is based on with a valve sheath, a DD trap or mechanical vacuum sources. With catheter may be used. DD trap जो right side में upper part में है DD traps. ठीक है, actually वो infection मतलब क्या infection है वो चेक करने के लिए भेजा जाता है, उसमें कलेक्ट करके इसमें भेजा जाता है. Recommended suction pressure for infant ये हो गया, ब्लॉक हो गया, और infant और pediatrics will be range from 60 to 80 negative pressure होता है. Okay, that's just positioning है. Positioning of the patient 100% oxygen supplement दिया जाएगा पहले, so that complications as less as possible होगा. Percussion, vibration हमारा टेक्निक यूज करेंगे, उसके बाद डिटच करना होगा, फिर सक्शन करना होगा, फिर इसमें हम थोड़ा एक्स्ट्रा ऑक्सीजन 100% ऑक्सीजन देंगे, फिर हम डिटच करेंगे, फिर हमारा टेक्निक यूज करेंगे, तो स्टेप बाय स्टेप होगा. साथ जैसे बोल रहे थे ये प्रैक्टिकल एक्सपोजर चाहिए तो ही पता चलेगा, नहीं तो कुछ पता नहीं चलेगा. ये नहीं कोई पेशेंट का सक्शन, ये बहुत पुराना मेरा बना हुआ है, पीडियाट्रिक आईसीयू में है, जब मास्टर्स कर रहा था उसी टाइम का है, मेरे ख्याल 2006-7 का. मास्टर्स भी मैं प्रॉपर्टी की है, काफी लेट किया. ओके, दिस इज द मेजरमेंट. यू कैन टेक द स्नैप. ये डिस्कस करने का टाइम नहीं है, ये बहुत इंपॉर्टेंट है कि वो जो बच्चे का वेट क्या है और उसके हिसाब से सक्शन कैथेटर का मेजरमेंट होता है. ओके, प्रोसीड्यूर जैसे हम डिस्कस किया है, अपना ख्याल रखना है और अपना वो जो हाथों में जादू है हमारा, इसमें पता चलेगा एग्जैक्टली कितना जादू आप डेवलप कर सकते हो अपना. ओके, कुछ स्टेप्स बहुत इंपॉर्टेंट है, जैसे पहले भी डिस्कस किया, हैंड वॉश करना है, स्टेप बाय स्टेप करना है. जैसे इनसाइड आईसीयू एंट्री करने से शुरू करके जो जो प्रोसीजर हम करेंगे पूरा कंप्लीटली साइंटिफिकली फॉलो करना है. ठीक है, ये हम आपको भी टेम्पा लूज नहीं करना है इनसाइड आईसीयू. आपका गुस्सा होगा बाहर छोड़ के, आप नहीं तो अंदर नहीं जाना है. दैट इज वेरी वेरी इंपॉर्टेंट. आप अपना टेम्परामेंट लूज करोगे, पेशेंट का लाइफ चला जाएगा. ठीक है, दैट इज नॉट एक्सेप्टेबल. मैनुअल हाइपर इंफ्लेशन टेक्निक, दैट इज द टैम्बू को कैसे यूज करोगे, दैट बेसिकली मैनुअल हाइपर इंफ्लेशन टेक्निक. ओके, these are the pressure manometer. राइट साइड, ये यहाँ पे लेफ्ट साइड में जो देख रहा है प्रेशर मैनोमीटर. प्रैक्टिकली मेरे पास तो सामान है, लेकिन नावे और वापस नहीं किया है, हिला नहीं हुआ. ठीक है, बट दैट इज वेरी वेरी इंपॉर्टेंट. कितना प्रेशर जनरेट कर रहा है, वही बिहार यू आर प्रेसिंग द एम्बू, पता चलता है. एम्बू प्रेस करने का टाइम ऑलवेज जस्ट शॉर्ट में बता देता हूं. एम्बू जब प्रेस करोगे डायरेक्ट इंस्पिरेशन के साथ, ओके, एक्सप्रेशन में नहीं करोगे कि क्लीन हो जाएगा, ये वो थोड़ा हो जाएगा. ओके, पोस्चरल ड्रेनेज आपको टेक्निक पता होना चाहिए. चलो ठीक है, छोड़ देते, टाइम नहीं है. तो इस तरह बुलाएंगे तो हम अलग से बताएंगे. ठीक है, ओके, थैंक यू फॉर लिसनिंग.
Thank you so much, sir. Now, we would like to invite our Honorable Vice Chancellor, sir, and Dr. V.P. Gupta, sir, to felicitate Dr. Pradeep Kumar Sarkar, sir.
Using all these ambu bags and all these techniques are the role of physiotherapists only. दूसरा नहीं करते लेकिन हम भी करते हैं ना
Intensive care is a combined responsibility. Whenever required, of course, you need to do teamwork. Save the life of the patient. You should be trained to perform any action which is required for the patient, including CPR, including intubation, including your implant, including examination, including positioning, everything. Ventilation, manual habilitation. So all these instruments are common for every nurse training, anesthetist, physiotherapist, everyone.
combined it.
And this one keynote concludes, another begins. It is my privilege to introduce Dr. Girinder Rai, Professor at the School of Physiotherapy, Delhi Pharmaceutical Science and Research University. She holds MPT in Cardiovascular and Respiratory Physiotherapy from TN Medical College, Mumbai, and a PhD from Maharaja Sayaji Law University, Baroda, with over 25 years of experience. With her expertise include ICU care, preventive cardiology, cardiopulmonary rehabilitation, respiratory care, and community physiotherapy. She is also a certified yoga therapist, passionate teacher, and long life learner. Please, ma'am, welcome to the stage.
Thank you so much. May I take this opportunity to first thank the organizing committee to call me here for this wonderful program that we have. With this, I would also like to come back there to the students behind. They've been listening to us since a long time. Can I ask you some taglines? Can you tell me what is just do it? When I say just do it, what is it? Can I show you the action? Just do it. Tagline for which brand? Nike. Very good. Who was that? Who was that? Very nice. A round of applause for him. I see a lot of girls sitting here. Okay. What is this tagline? You're worth it. Come on. You're worth it because you're worth it. Boys? It's L'Oreal, right? L'Oreal Paris. I heard it there. Okay, what is your tagline? Come on, UEM. What is your tagline? What is your tagline? Very good. Good education, good job. But I can see something authentic here. Shraddhavan Labate Jnanam. From where does this come? Bhagavad Gita. Sir knows it. So do you know it? It is coming from Bhagavad Gita and it says that if you have a deep focus, a good control over yourself, you will be acquiring good knowledge and eternal peace. The entire verse says that. Okay. What are we doing nowadays? We are losing control. And we are asking things like psychoactive substances like caffeine and many other things, and I don't want to name them up. And we are let them take over ourselves. Do we want them in life? So I have a practical experience to share with you that why I don't want you to start your day with caffeine. How many of you drink coffee? Come on, people. How many of you drink black coffee in the day to start your day? Okay. Good, I can see hands coming up there. Last bench. I am happy I could take your attention. Thank you. So if I have you there, the last bench there, you need to know these things that I'm going to discuss here before we decide whether you should still take caffeine or not. Though I'm a cardiopulmonary specialist and I work a lot in ICU, have worked a lot in ICU, and whatever Pradeep Sarkar sir has shown here has been very close to my heart. But recently I have decided to move more towards the youth and their habits. So that's why I decided to do this study for females though, but it does apply, the findings of it does apply for the males also. So let's discuss effect of caffeine on cardiopulmonary responses during the follicular and luteal phases of menstrual cycle. In particularly, I'm going to discuss about caffeine, menstrual cycle, and exercise and recovery. So if I talk about caffeine, we all know it's the most commonly used psychoactive substance today. Your tea, your coffee, your chocolates, what not have caffeine in it, right? And a dosage of around 500 milligrams may cause ill effects and reduced performance levels and can make a person more anxious than what you actually wanted. You just wanted to become active, but now you are becoming anxious and your work is going to suffer. Okay, so this led me to ask a question because we are doing stroke patients here. We are also discussing about stroke patients here. We are already habituated to this caffeine, but after this stroke patient who has had a stroke attack, does he still have to have this caffeine before he does these exercises? So I want to see the cardiopulmonary effects of exercise in normal sedentary females. That is because I had to limit my population to sedentary females. I did it only on sedentary females to have its application on other patients. Is the application, but I can discuss some physiological. Are you listening? The one who drinks coffee every day. So what are the phases of menstrual cycle? Because we have time, so I'll just be quick. So here you have the menstrual phase. The pointer is not working that well. So the menstrual phase followed by the follicular phase. So the 1 to 5 days is the menstrual phase, the red one that we start with. Then 1 to 13 is your follicular, followed by the ovulation at around the day 14, and then you have the luteal phase that comes after the menstrual period around 21 days. So what we did was, this was a small limitation that I have put in there, that we've not taken hormonal evaluation of the females, but we tried to target their menstrual cycles with an application for almost 3 menstrual cycles that they had. And then we noted that which one was plus 7 day and plus 21 day, and accordingly we phased them into follicular and the luteal phase and tried to take the data. So then, why are we discussing this? So the caffeine is basically going to antagonize, I think it's a LED screen on which this will not work. So antagonize A1, A2A adenosine receptors, and sodium potassium ATPase pump is the place where it works. So it is not going to let the A1, A2A adenosine receptors work, because of which there is increased sympathetic drive, increased catecholamines, and that is why you are able to focus. The thing that I started with. If you have deep faith and you focus, you get the knowledge. You're trying to focus, but what are you in turn? If you have it in regulated doses, it's fine. But when you overdo it, it's not fine. So what is this that we do to ourselves? So we just thought of finding out that does caffeine have any effect on exercise-induced heart rate, blood pressure responses, and post-exercise autonomic recovery on the pulmonary parameters like FEV1, FVC, and PEF after exercise? And are these acute cardiopulmonary responses going to be different for different menstrual phases?
Yes.
Post-exercise cardiopulmonary responses during the follicular and luteal phases of menstrual cycle in sedentary females. And here we had blinded the people, so you were not knowing whether you are having a caffeinated coffee or a decaffeinated coffee. And because of that, definitely you don't know what the results are going to be there, right? So this is something that we do in our day-to-day lives. So we almost approached 82 people, out of which we could randomize 60 into 2 groups for the control group, and that is a placebo group, and the caffeine group. And we tested them in both the follicular and luteal phases. Only limitation there again was we did not cross over them. The same sample was not crossed over. We just took the same caffeinated group, follicular phase, luteal phase, decaffeinated group, follicular phase, luteal phase, and we compared because of paucity of time. We did not cross over them. So we have a limitation. The eligibility profile was very clear. It was an age group of 18 to 30 years. BMI was normal standard BMI as per WHO criteria. Sedentary females, less than 600 meds as per the International Physical Activity Questionnaire. And obviously we have monitored them on an application for their regular periods so that we don't take people who have dysmenorrhea and other problems. Nulliparous, 0 to mild caffeine users, like less than 100 milligrams per day, we allow them in the study. So the key exclusions were people having some problems with their menstrual cycles, pregnancy, lactation on hormonal contraceptives, and history of relevant systemic conditions or disorders, smoking, alcohol, or any other drug abuse. We randomized them as I told you. So the most important part here is that they were blinded about the beverage appearance, color, temperature, volume, and cup size as they were matched. Phase identification, as I told you, was done with the help of an application. So we did a pre-standardized testing, no caffeine for 24 hours, avoid strenuous exercise for around 8 to 24 hours. Light feed was allowed for around 2 to 3 hours before testing. Baseline, we took the heart rate, systolic BP, diastolic BP, and pulmonary functions. Then we administered the beverage. Around 300 milligrams of caffeine was given in form of a coffee shot in 100 ml of water without milk. And same way the decaffeinated coffee was also administered. Absorption period was around 30 minutes. This is evidence-based. We see that there is an absorption after 30 minutes. So we gave an absorption period of around 30 minutes. Rest. We measured the cardiovascular parameters again. And we did a valve protocol on the treadmill as described here. Those are guidelines. And we terminated the exercise if the person has reached his target 60% of his heart rate response. Recovery, BP, heart rate, after noting the peak heart rate, systolic BP and diastolic BP, we noted the heart rate recovery, the BP recovery for 1 and 2 minutes, and the time to recovery if they have not recovered in 2 minutes. So yes, UEM, tell me if a person does not recover in 2 minutes, what is the problem? Why should I see him, observe him for more than 2 minutes? Are you aware about your autonomic nervous system, sympathetic and parasympathetic drives? Are you aware of autonomic nervous system, parasympathetic and sympathetic drives? Alright. Why do we have to keep our parasympathetic dominance more than our sympathetic dominance? That's the question for the generation today. We have actually started playing with our circadian rhythms. We have started using more of psychoactive agents, and we are actually approaching doom day by day. You've lost control and focus on your own self. We need to come out of that. Please understand this small research on sedentary females is giving you an idea. So we did the data was tried to we analyzed the data for the assumptions, and we found that the cardiac outcomes had normality, but the pulmonary outcomes had a non-normal distribution. So we had to apply non-parametric tests for them. We'll be discussing all these tests. We'll be discussing all the results in detail. At baseline, my population was almost comparable. I'm not going into details because of paucity of time, but they were comparable. So this data means basically they were comparable at baseline. If I see the cardiovascular responses, now this is an important slide. I know you have a rumbling stomach. We are approaching lunchtime. Just give me 2 minutes and I will just wind it up. Okay? So we see the cardiovascular responses on the red one, that is the caffeinated, and the green one, that is the decaffeinated. So we are seeing that in the caffeinated, post heart rate and post systolic BP and diastolic BP are all three of them. You can see they are significantly higher in both the follicular and luteal phases. So we don't have a statistically significant difference between the phases, but yes, we do have a difference between the caffeinated and the decaffeinated group. All right. Then the post-exercise recovery goes also altered. They are not recovering on time. They are taking longer to recover, and not longer by only just 20 seconds or 30 seconds, by almost 117 seconds that they are taking to come back to recovery. Means your parasympathetic dominance is not coming back on time. How do you train it? We train it through regular exercises. Let's talk about the pulmonary responses. Definitely, they have also deteriorated in your caffeinated patients, in subjects, sorry, in both the follicular and luteal phases. Only PEFR, which is effort-dependent thing, has shown a significant increase because we have stimulated your sympathetic drive. This is what we are presuming out of the physiological evidences. So it's the diastolic BP that I'm more worried about, that has happened or has shown changes between the follicular and the luteal phases. We assume that there is an enzyme in the liver which is called CYP1A2, which actually takes care of the excretion of these chemicals that are there in the body, and this is dominated by this luteal phase high hormonal levels, because of which the caffeine is not extracted, and so you may feel a little more jittery during the luteal phase if you have taken caffeine just before your exercises. None of the responses were actually valid. So what is basically the result of my study? The clinical implications. Acute caffeine may meaningfully increase cardiovascular load and prolong your recovery after exercise. Most of us want to drink it in the morning and then go for our exercise. First, in stroke, female health context and sports physiotherapy. We also have systematic reviews with accuracy and reaction time following caffeine consumption improves. But do we want that to improve in the patients at the cost of their autonomic nervous system? That we have to figure out. Stroke is a major problem of long-term disability and may result in persistent impairment in the function, mobility, balance, cognition, activities of daily living. Do we actually want to change our prescription of caffeine for these patients before they come to us for exercise? Or do we also want to do it for ourselves occasionally? I'll leave a question behind. What are the future researches that I leave to students? Larger and more diverse sample size, direct hormonal assays can be done if you have the provisions in your university. Comparison across all menstrual phases in the females, multiple caffeinated doses can be given. Chronic habitual usage can also be checked. Advanced neurological, cognitive, cardiopulmonary and psychoactive measures can also be checked for these patients. Thank you everyone, and I now the stage is open for any questions that you have. Don't forget your tagline. Don't let these psychoactive substances take a hold over you. You have to take a hold over yourself. I sometimes feel that as a student, you should stand up and take a pledge for yourself that I take a hold over myself and I'm not allow any psychoactive substance to take over a hold of me. You know, sugar is also as addictive. That's why people have started taking it as an addiction and say no to drugs, cancel the drugs, it's sugar now. So we need to get rid of this refined sugar also, right? So please be very, very choosy about what you eat, because it's the gut which has most of the dopamine receptors, and you're going to get your endorphins from there, and your whole body accessible from your gut. Even Parkinson's, a disease, a neurological disease, has shown its origin from the gut. So what you're eating at this age is going to matter. So even exercise is very, if I understand, exercise is also very addictive, because the myocytes have satellite cells which actually store the impulses, and they will actually keep you working all throughout. So take that addiction. Why do you want to take psychoactive as addiction, right? So please try and train yourself for exercise, keep yourself active, and on this note, I will thank you everyone again for your patient listening. Have a great day ahead. Okay, or black coffee moderation is okay. You need to have, and you need to decide the timing that you are taking your black coffee. That is more important.
At least half an hour gap from food.
Preferably, see, these are all nutrition related questions that you're asking me, but what I have found out that immediately after absorption is done, then it is going to have an autonomic modulation in your body. And the thing that you're asking, definitely we have black coffee, several advantages that are coming up with black coffee. Correct? And I know that, and I use black coffee myself for those things. But we need to time it properly before we have it. So everything in excess is bad. We've been hearing this since the beginning. So yeah, so everything in moderation is completely fine. Again, everything in time, the proper time is again fine. That is why I again say that come back to your circadian rhythm. Let's start the day at 4 o'clock and let's finish it by 9 o'clock or 7 o'clock in the evening. That would bring us to a better world tomorrow, I think. Yeah, thank you.
Thank you, ma'am. Now we would like to invite VC sir and VP Gupta sir to felicitate Dr. Richa ma'am. So, ladies and gentlemen, we will now take a lunch break from 1 p.m. to 1:30 p.m. Please take this opportunity to refresh yourself, connect with fellow participants, exchange thoughts, and of course, enjoy delicious meal. Thank you.
Requesting all to come back in time.
And I requesting to all of you to please come back on time.
UEM Jaipur sir अभी lunch hour है तो आप ये lunch hour के 20
Everybody, please keep
I don't want you to be one sitting listening to my lecture. The more interactive session, the more it will be lively. I remember this transformation, transition of knowledge or techniques in three different fields of our profession: clinical, academic, research and administration. I done my graduation in 1992, 88-92. Those days, we used to have class with blackboard. Hardly we used to have 10 classes in a year. We had only 4 books for us in British Library, Mount Road, Chennai, Tamil Nadu. We had to go to library there to read the books. Of course, the clinicals was enormous. We used to have more than 100 patients in a day in a OP. And in the first year, we were asked to look the seniors, to look at the patients, feel what is going on in the clinicals, and then we are given a chance to move the patient only in the 3rd year or 4th year. So look is very important. Now I have to look at your faces and then take class, so that whether you are attentive to my class, if you feel bored, I have to stop and do some exercises. And also I should feel that you are committed in this conference. Only then I can be active in delivering my lecture. Yes, of course, I'll move the slides after feeling that you are committed in the workshop. If not, it doesn't carry any meaning for me or for you. In academics, so in academics we had blackboard, then came the overhead projectors. I don't know whether you have seen that or not. We used to write in the OHP sheets and then present class, and now we have the latest projections. Olden days, when we want to transform the knowledge, we never used to have mics like this. Who has got good voice? They are the good academicians. They used to take classes without mic. Even now, most of the colleges doesn't have the mics. Now we have mics. Now we have Google Mother in our hand to have the knowledge which is spread. But what is the difference between the Google and the teachers? Google gives the opinion of millions of people and put it to you. The teacher delivers their own experiences which they had with the field, which is expressed to the students according to the feelings of the student. So they try to see whether the student is observing or the student is able to catch the point. If not, the teacher will try to explain as required for the student, which Google doesn't do that. It starts delivering its own lecture. Whether you catch it or not, it's not the matter of the AA. But teacher is not AA. Teacher is able to do psychological support as well as the physical support, which makes you to go into the society with the social support. So let us see the research aspect of it. Even our history says there were a lot of documentation which were existing, which was called as Talapatra, which they would have written in leaves, and it was stored. We were still to explore those documentations
which is now done by most of the countries. Now, we are lately realizing that documentation is required because this generation believes only on documentation. So that is what is the transformation. Let us see how this transition of the knowledge has been in cardiac physiotherapy. This is my institute, Sri Venkateswara Institute of Medical Science, which is down the foothills of Tirumala, Lord Balaji. This is my college of physiotherapy with ground floor with OPD building and first and second floor with classes. And this is what I want to say, how this transition of techniques have reached to exercise testing, prescription and endurance. So historically, how physiotherapy started, cardiopulmonary physical therapy started with the World War when the soldiers were injured. There was a thoracic injuries, they are put into the postural drainage and all other things, and they were being brought back to the normal. Then it was realized, yes, physiotherapists need to be trained in a structured form, and there the journey of cardiopulmonary physical therapy started. In early 20th century, it was postural drainage, percussion and vibration, now with latest equipments. So I keep moving the slides because there is also a signal, it is too late, ma'am, you have to move. And there was an evolution of breathing exercise before, basic techniques, and we never understood how this oxygen transport occurred, and which is very basic principle of cardiopulmonary physical therapy. The taking of oxygen from nose goes all over the body, lungs, heart, and makes us live with ATP energy as well as the oxygen which we breathe. This importance is very much has to be understood by cardiopulmonary physical therapists. Only then you will realize not only breathing exercise, mobilization is also important in cardiopulmonary physical therapy. So from foundation it has gone to modern exercise science, a journey where the transformation, transition and techniques and its application. So as I said, it started with this main basis on lung function during with the respiratory conditions. But later, now it is explored. Cardiopulmonary physical therapy is not only with cardiac function or not only with the respiratory. It has its role with every conditions where cardiorespiratory capacity and endurance is very important. Either it starts from pediatric to geriatric, it starts from the medicine to the medical oncology, surgical oncology, radiation oncology, women's health, sports, everywhere. So it has started its journey like this. Is it visible? I think it's not visible for the last benches. So it has started first with an only heart attack survivors where they were given only bed rest. They were asked to take bed rest for 3 months. Later it came for 3 weeks. Now it is within 1 hour they are asked to mobilize. That is how the transformation has occurred with the scientific evidence, and now it has reached to multidisciplinary approaches, and we are there within all ICUs, because even morning you are seeing the speakers talking about ICU management in pediatrics to the caffeine where the cardiopulmonary conditions exist. So this 1950 was only physical activity for cardiac, and my key milestones were ICU management and early management, and now it is the development of aerobic training concepts. The transition, this video is not playing, but I said it is in a combination of clinical, academic and research, where it started within a conventional, now it has gone into modernized concepts. So it was
was a transformation of chest physical therapy. As morning sir was saying, clapping is the one which we used to do. Now, none of the students know how to do clapping because we use mechanical vibrator in ICU nowadays. So if we ask a student to clap, I ask all NPK exams when I go to do first demo the clapping, do the vibration, do the shaking, because all this mechanization can stop at any time. When it stops, we should know how to do it. This slide projector can stop immediately if there is no current. I should be able to take class even without this slide protection. That's what we have to develop ourselves. We should not forget the roots where we have started and try to acquire, and what is transformed or what is the advanced which we have learned is more easily accessible for the professional as well as the patient, which can make it more easier and it is economically cheaper. But still we should have a strong root foundation. Without that, how we can do it even in the rural community, because India is made up of more of rural community rather than the urban area. So when you are going to rural, you should know how to explore your profession in the rural areas. So this is what chest physiotherapy, which is breathing exercise and clapping and incentives parameter is the advanced one. So the transition which has started with clapping, then it has gone to the mechanical vibrator. Here we used to have postural drainage. We used to see number of bronchiectasis cases in 98 where we put them into postural drainage. But with the advanced antibiotics and other techniques, now it is not the postural drainage which we are adapting, it is the ACPT technique which we are using to clear the secretion. Coughing is the one which was there, which was initiated initially. Now we have forced expiratory technique. One thing I would like to say, when you say coughing technique, you should not ask the patient to do coughing. You should know what is the stages of coughing. Try to analyze which phase of cough reflex the patient is missing. That part you need to train. I see many of our students going to post-operative ward. As the patient is saying, my difficulty is coughing, then you ask again, you please stop what you are making exhausted and faint. You should know how to analyze the cough mechanism and try to motivate or try to assess and rehabilitate that part of the mechanism of cough mechanism. ADL. So these are the things, activities we always say you have to do brushing, this. But now we have even the feedback mechanism where the patient, you can make them sit in front of the biofeedback mechanism and say, this activity you are lacking here. So you need to improve. This can happen in advanced clinic, but it cannot happen in a rural. There you have to use mirror therapy. Use mirror to analyze how the activities needs to be activated, and that can be the advanced one. So we have a transformation of these machines which can increase your lung capacities, clear the secretions, and you have an evidence-based practice for everything. The researchers are coming with different protocols, but we need to concentrate on 3 different aspects. The prevention is more important along with the therapy. And when you are doing a therapy, you need to do progressive exercises and try to see how he is responding, and accordingly you need to frame the protocols with a psychological support. So the protocol doesn't mean it stands for all the patients. You have to modify according to the need of the patient. And don't say that first day I have to do this, second day is that. You see how the patient responds, and accordingly you need to modify. And it is a scientific, systematic and structured protocols which you need to do. So this is how the conventional to the advanced it has come up with different conditions which was there. Started with chest feeding, now we are doing with exercise testing and prescription. We try to assess the patient and then show where he is and what needs to be prescribed. So every patient, either with a neurology or cardiac condition or any other condition, we try to evaluate the capacity of an individual and then prescribe the exercise. Of course, the testing techniques are treadmill, cycle, and 6-minute walk test. And you prescribe the exercise based on fit principle. And what type of exercise we give is aerobic exercises, resistance and flexibility training. And you have to monitor the safety during the therapy. Fit principle, of course, you are new, but this is what is fit principle. You should know what is the frequency of exercise it should be given, what should be the intensity, what should be the time and the type of exercise you need to do. To do this, you should know how to calculate the formula, Cardiovascular formula, which helps us to know how to prescribe an exercise. So, what is your goals and how you need to individualize? The first phase is always stabilization. The second phase is a recovery. The third phase is a maintenance phase. So, based on that, you have to give an individualized therapy for the patients. So, endurance training, of course, the benefits what you get is improve the cardiac output, oxygen utilization, and respiratory muscle strength. So, this is how the endurance training benefits which is given, and what types of training can be given. It can be interval, it can be continuous trainings which can be given for the patient, or progress the exercise according to the response. You will get a fast recovery with different types of training, you will get a fruitful result, and the patient will be able to move freely. So, primary difference between the conventional and advanced is techniques, technology, and approach to mobilize and clear the secretions from the lungs. Both are the same, but the effort given will be different. It differs. Conventional, you will have to put more effort, whereas in advanced, effort is less by the physiotherapist. So these are the advanced technology assisted movements, customized therapy you have, increased independency, comprehensive approach, efficiency, applications, and cost and accessibility for the patient. In summary, I would like to say that conventional physiotherapy is relaxed and advanced is more improves the efficiency, independent, and it can do suitable for more complex cases. So it may involve higher costs and training. What is conventional? You should know advanced, and you should know when to adapt conventional and when to adapt the advanced techniques. So definitely the challenges and adherence is still existing in the society. Not getting exercise adherence in the public. We need to concentrate on exercise adherence, which is very challenging issue, and we have a resource limitation and accessibility. Of course, cardiopulmonary physical therapy is the one which all of them doesn't take as a first priority, because we don't see what is going on inside the body. You don't see how heart functions, how is heart responding, and if something happens, immediately there is a lot of changes which occurs lead to the death. So most of them stay away from the cardiac specialties because it's quite challenging. So, but this is an allowed specialty which needs to be. So, integration of wearables and AI devices has made it more comfortable with cardiopulmonary physical therapy, because visually you are able to see what is happening inside the body with the feedback mechanism, and we can accordingly make the changes. Applications, AI is going to be very helpful in real-time feedback and predictive modeling in the cardiopulmonary physical therapy. So it is more accuracy and efficient in decision making and making so subtle trends in
patient data. Of course, there are challenges in the data management, which needs to be streamlined. These are some of the wearable technology, and morning also there was a discussion about tele-rehabilitation. As COVID has made us think about this tele-rehabilitation, even now we can adapt this and see how it can be useful for the patient. Simple smart telephones can help to do the exercises in the homes and we can monitor the rehabilitation and try to avoid these chronic disabilities, because most of them are not able to come to the clinics because of the transport and other charges. So we can make this tele-rehabilitation for the patients, which is more comfortable. So this is transformation of the techniques. Through tele-rehabilitation, technology and device, we need to explore, excite, and entertain with your inner and make it more likely for yourself or the patients to do the exercise. Any queries? I advise all the students to start breathing exercise before you start your class. I ask all the teachers to start breathing exercise in every class and do heel up and heel down before starting the class, and cool down period again with breathing exercise after the class. Thank you. Thank you.
Thank you, ma'am, for an enriching session. Now, we would like to invite VC sir and VP Gupta sir for felicitation of Dr. Madhvi ma'am. Give a huge round of applause for them. And now, it is our privilege to welcome Dr. Ijaz Ashai, a distinguished physiotherapist and sports rehabilitation specialist. He holds a Master in Physiotherapy in Sports and has received specialized training in knee, shoulder, and spine rehabilitation from the USA. He has served as a consultant to prestigious teams including the Mumbai Indians, Indian Rugby Team, Ranji Trophy, Pro Kabaddi, and ATP Tennis. Please, sir, welcome on the stage.
Good afternoon, everyone. नींद नहीं आ रही है ना? मैम ने इतना एक्सरसाइज करा दिया, नहीं? We'll add one more exercise. करें या नहीं? Both hands behind the neck, elbows straight out, and pull your elbows, hands forward, and push your neck behind. जितना जोर से उतना जोर से. Feel that stretch coming on the back, upper back. Try that harder. Good. Now hold your tummy in and do it. So what happens with that? हाँ? क्या होता है इससे? Because जब हम 4 से 6 घंटा बैठते हैं एक जगह पे, so we have something called lactic acid in the body. तो accumulate हो जाता है mainly यहाँ पे. जब आप कंप्यूटर पे बैठते हो या पढ़ाई करते हो ना, एग्जाम के लिए, the first thing what happens is this part gets stiff. तो आप frustrate होने लगते हो, stress होने लगता है. So whenever you get a chance, sip of water and stretch like this. बैठे. Okay? And सबसे अच्छा जो सुबह से चल रहा था cardio. अब मुझे भी लग रहा है cardio is must. और सुबह से जो हम लोगों ने सीखा, चाहे आप स्पोर्ट्स में जाओ, चाहे ऑर्थो में जाओ, चाहे न्यूरो में जाओ, चाहे आप ऑंको में जाओ, you have to start with the heart, and that's the best thing since morning we have learned. Otherwise बाकी कॉन्फ्रेंसेस में बाकी चीजें भी होती है, but यहाँ कार्डियक से स्टार्ट हुआ तो बहुत ही अच्छा हुआ. ठीक है? So today what we will show you is 30 seconds of diagnosis and 3 minutes of treatment, right? करते हो आप? सुना आपने? स्पोर्ट्स देखते हो सब?
Yes, sir.
आईपीएल तो देखते हो ना?
Yes, sir.
होता है ना, जरा फटाफट जाता है फिजियो, ठीक करके आता है, तो बोलते हैं ऐसे कैसे इसको सब कुछ आता है. इसमें कोई ऑर्थोपेडिक सर्जन, कोई न्यूरो फिजिशियन, कोई फिजिशियन क्यों नहीं जाता है? हाँ, क्यों नहीं जाता है? वो भी तो जा सकते हैं ना, तो फिजियो क्यों होता है वहां पे? है ना, कभी देखा है किसी सर्जन को, किसी को वहां बैठे हुए? है ना, खाली एक फिजिकल थेरेपिस्ट रहता है जिसको हम लोग स्पोर्ट्स फिजियोथेरेपिस्ट बोलते हैं. हाँ, तो जो ही इंजरी होती है तो सबसे पहले प्लेयर क्या बोलता है? क्या बोलता है जब लगती है? तो क्या बोलते हैं? हे भगवान, अल्लाह, गॉड, यही बोलते हैं ना. दूसरा नाम क्या होता है ग्राउंड पे? डॉक्टर है. Where is my physio? सोचो आपका स्टेटस किधर होता है? गॉड के बाद आपका नाम आता है. किसका नाम आता है? किसका नाम आता है? हमारा नाम आता है. सिर्फ हमारा. We all are physios. ये हमारा नाम आता है, राइट? फिर जब आप वहां जाते हो, उसको ट्रीट करते हो और उसको खिलाते हो. व्हाट इज द स्पोर्ट्स फिजियो जॉब? अगर आप कभी स्पोर्ट्स फिजियो बने, so your job is to make the player play without aggravating that injury. इसलिए आप वहां पे हो. अगर रेस्ट देना है तो रेस्ट हमारे सर भी दे सकते हैं, रेस्ट एक ऑर्थोपेडिक सर्जन भी दे सकता है, रेस्ट एक फिजिशियन भी दे सकता है, रेस्ट एक कोच भी दे सकता है, मैनेजर भी दे सकता है. खिलाना without aggravating that injury. That's our job. अगर आपने वो किया और आपने खिलाया उसको, so you are the best. अगर नहीं हुआ तो we are not worst. We tried our best. Remember that we are just a human being. हम लोग क्या है? फिजिकल थेरेपिस्ट है, फिजियोथेरेपिस्ट. हम लोग भगवान नहीं है. हम लोग कर सकते हैं. अगर आप रिसेंटली एक पॉडकास्ट देखोगे, उसमें काफी डॉक्टर्स बुरा भी मानते हैं. मैंने सेड एनी डॉक्टर इन दिस वर्ल्ड, अगर कोई भी दुनिया का डॉक्टर बोलता है मैंने किसी को ठीक किया, दैट डॉक्टर शुड बी हैंड टिल डेथ. कोई भी डॉक्टर दुनिया का किसी को क्योर नहीं कर सकता. हम लोग किसी को क्योर नहीं कर सकते. व्हाट वी कैन डू, कैन ट्रीट बिकॉज़ वी हैव अ मेडिकल नॉलेज बिहाइंड इट. तो कभी भी आज के बाद बोलना मत कि मैंने ठीक किया. मैंने ट्रीट किया. अब ठीक होना ना होना ऊपर वाले के हाथ में. इसलिए आपको कोई ब्लेम भी नहीं कर सकता मैं ठीक क्यों नहीं हूं. तो सब अपने डोर पे लिखना, वी ओनली ट्रीट, वी डोंट क्योर. ठीक है? क्या लिखोगे? वी ओनली ट्रीट, वी डोंट क्योर. जब आप ट्रीटमेंट करते हो तो वो ठीक होता ही होता है, क्योंकि आपका ट्रीटमेंट. तो पहले आप वीडियो दिखाता हूं यूनिस का
थर्ड स्टेज.
I'll show you one of the videos जिसमें injuries आप देखोगे. डिस्कस करेंगे. अच्छा चलो, ये याद है आपको? पीछे लेंगे उसको स्टार्टिंग से. ये याद है?
Yes, sir.
इसकी वजह से हम लोग वर्ल्ड कप हार गए थे. हारे थे ना, क्योंकि यही एक प्लेयर था जो परफॉर्मेंस कर रहा था, इसका इंजरी हो गया. ये देखो, इसको आगे लेके पॉज करो. और आगे जब ये चल रहा है ना तो भी पॉज करो. और आगे और आगे और आगे और आगे और आगे और आगे थोड़ा सा. बस बस इंजर्ड हुआ कौन है ये? इसके लिए क्या कर सकता अंबानी? इंजर्ड होगा तो हेलीकॉप्टर नीचे ग्राउंड पे लाके लेके जा सकता था। क्या किया हमने? इंजरी के बाद चला कितना बाउंड्री लाइन, उसके बाद स्टेप चढ़ाया, तो ये सेमीफाइनल नहीं खेल पाया। तो मैंने खाली एक स्टेटमेंट दिया था ट्वीट पे कि वी आर रिस्पांसिबल, इंडिया लॉस्ट बिकॉज ऑफ लैक ऑफ मनी। हम सब ने हरा दिया इंडिया कि वी में बैग लेके हैं, ये हमारे वहां चल रहा है इसको हमारे दिमाग में होता है we have to play safe. Safety is the first thing. अगर इसको इंजरी हुआ, they should have taken him on a stretcher, take him inside, ताकि इंजरी एग्रीवेट ना हो. This is not a mistake. This is a blunder. एक जैसे कार्डियोलॉजिस्ट एक सर्जरी करता है हार्ट का, वैसे का ये काम होता है यहाँ पे कि मैं कैसे प्लेयर को कल के लिए तैयार रखूं. और यहाँ हमने खत्म कर दिया. जो प्लेयर पूरे सबसे ज्यादा रन बना रहा था, विकेट ले रहा था, हमने उसको बाहर कर दिया. किसने किया? हमने किया. So this is to learn. जब आप ग्राउंड पे होते हो, you cannot take it for granted. चाहे वो स्कूल का मैच हो, चाहे वो वर्ल्ड कप. आपको देखना है कि आपको सेफ कैसे रखना है. So ये वीडियो हम लोग अपने फिजियो को इंसर्ट करने के लिए नहीं कर रहे हैं. हम लोग ये दिखा रहे हैं कि हम कल को ये रिपीट ना करें, अगर आपको अपॉर्चुनिटी मिलती है तो. राइट? तो काफी लोगों ने बोला है तुमको ऐसा नहीं बोलना चाहिए, ऐसे बोलना नहीं चाहिए, आपको समझ आना चाहिए. 170 करोड़ में से आप 16 प्लेयर चुनते हो और 170 करोड़ में से एक आदमी चुनते हो जिसको फिजियोथेरेपिस्ट बोलते हैं. 170 करोड़ में से वो कैसा होना चाहिए? मोदी साहब से भी अच्छा होना चाहिए. राइट? एक आदमी होता है जिसके पास मेडिकल नॉलेज होती है क्रिकेट में और किसी के पास नहीं होती. और अगर आप वहां नहीं दे सकते हो, डिलीवर नहीं कर सकते हो, तो आपकी जगह वहां नहीं बनती. क्लियर? तो इसलिए कार्डियो से स्टार्ट करो और स्पोर्ट्स इंजरी पे आ जाओ. ऑलराइट, ये एक स्लाइड था. देन आई विल शो यू वन ऑफ द स्लाइड जहां आप इंजरीज देख सकते हो पूरे. Alright, what is this? मैं हाथ को पीछे की तरफ खींच रहा हूँ. What is this? Is this stretch or is this strengthening exercise? हाँ? कितने लोग स्ट्रेचिंग बोलते हैं इसको, जो हाथ को पीछे खींचते एल्बो सीधा रखते हैं? How many people are saying this is stretch, this is not strengthening? हाँ? तो whenever हम लोग जैसे हाथ ऐसे रखे, तो क्या आप देख लो पहले. पटेल डिसलोकेशन, हाँ क्या कर रहे हैं ये लोग, इसको हेल्प कर रहे हैं। क्या करना चाहिए, क्या करना चाहिए इसमें, इसको चलाना चाहिए, बिठाना चाहिए वहां पे। इनसे आप कोर्स सीखते हो ना, ये आपको ऑस्ट्रेलिया से साउथ अफ्रीका से आते सिखाने के लिए, जिनको आप 40,000 रुपया भरते हो कोर्स करने के लिए, लेकिन आप अपने लोगों से नहीं सीखते हो। आपके जो सीनियर्स हैं, आपके जो टीचर्स हैं, आप उनसे नहीं सीखते हो। लेकिन एक जो फॉरेनर आता है, विद ड्यू रिस्पेक्ट टू ऑल द फॉरेनर्स, आप जाके 40,000 रुपया उसको देते हो, कोर्स करते हो वहां से, सर्टिफिकेट के लिए, नॉलेज के लिए नहीं। आप अगर पढ़ते हो तो स्टडी फॉर नॉलेज, एग्जाम के लिए मत पढ़ो। अगर आपको, क्योंकि ये जो फर्स्ट से 10th तक या 12th तक हम पढ़ते हैं, वो हम लोग कुछ नॉलेज के लिए पढ़ते हैं, कुछ एग्जाम के लिए, कुछ मार्क्स के लिए। लेकिन जब आप एक प्रोफेशनल कॉलेज में आते हो तो आप एक पढ़ाई करते हो कि आपको किसी की लाइफ को ठीक करना है, उसको आप एग्जाम के लिए तैयारी नहीं कर सकते। पहली बात, रोहित शर्मा का शोल्डर बार बार बाहर आता हुआ ऐसे वापस डाल देना, देखा मैच कितनी बार वो शोल्डर उठा के वापस डालता है। वो हुआ 2007 में। सो वी टॉट हिम हाउ टू पुट द शोल्डर बैक, तो उसको सर्जरी की जरूरत नहीं पड़ती है। आज अगर मैच में उसका शोल्डर बाहर आता है, सो वी नो इट्स नॉट इमरजेंसी। यहाँ पे अगर ये पहली बार हुआ है तो क्या करना चाहिए, वी डोंट अलाउ देम टू प्ले। अगर जरूरी नहीं है तो हम लोग इसकी रिप्लेसमेंट ढूंढते हैं। बट अगर ये रिकरेंट इंजरी है, we know she has a legs patella, she has a legs ligament, there is a laxity, so we are supposed to tape it and make them play. मैंने मांगा था, एक कोई है क्या, कोई मॉडल जिसपे दिखा सकते हैं, है कोई? कैसे करेक्ट करते हैं 30 सेकंड्स में इसको? सीखना है किसी को? किसको? क्या हुआ, पटेले डिसलोकेशन, निकाल दिया उसको, थोड़ा नी बेंड करो, इसका नी ऐसे रहेगा। क्यों पटेला लैटरली डिसलोकेट होता है, मीडियली क्यों नहीं होता है? वी ऑल नो कि मीडियली वेस्टस मीडियम, वो बोलते हैं ना आपको वीएमओ ट्रेनिंग, वेस्टस मीडियलिस मसल होता है जो नीचे तक आता है, इनर साइड ऑफ द नी कैप होल्ड करता है इसको, इसलिए लैटरल डिसलोकेशन मैक्सिमम होती है। तो हम लोग क्या करते हैं एज अ फिजियो, अगर विद इन फर्स्ट 30 सेकंड्स और विद इन 1.5 मिनट उसको अगर हम लोग वापस लाते हैं तो बहुत अच्छा है। इफ यू गेट लेट 3-4 मिनट्स द मसल गार्डिंग स्टार्ट्स, तो आप उसके बाद उसको टच मत करो, टेक हिम लाइक दिस टू द हॉस्पिटल, लेट ऑर्थोपेडिक सर्जन डू इट अंडर एनेस्थीसिया, क्योंकि इट्स वेरी पेनफुल अदरवाइज। लेकिन आज जब वार्म होता है, जो ही होता है, अगर आपको आप वहां पे हो, फटाफट कर सकते हो तो डू इट। How do you do it? So what you do? यहाँ हाथ रखते हैं, प्लेयर को पहले लेटा देते हैं, यहाँ हाथ रखते हैं, ठीक है, इसको हैंडल करते हैं। प्लेयर को बोलते हैं भाई घबराना मत, कुछ नहीं है, ये नॉर्मल है, डरने की कोई बात नहीं है। उसको सिर्फ बोलना है कि जब मैं हिट करूं तो नीचे पुश कर लेना इसको। So what we do? We hit it like this and we tell it to push it down. Okay? मैंने जब मैं हिट कर रहा हूं आप पुश कर लेना, फिर on the side and it comes in and hold it there. Once you hold it from lateral side पूरा,
and tell him to do isometric cortices fatafat. Push it down. So the isometric contraction comes and you're holding from the outer side, tape it. And you tape it quickly. So what we have seen, kinesio tape इसमें काम ज़्यादा नहीं करता है because kinesio tape wet हो जाता है. So we for stability we use rigid tape. हम लोग यहाँ laterally को फिक्स करके प्लेन को यहाँ साइड से नीचे लेके पहले medially उसको लेके आते हैं. So we pull the patella medially, hold it here, strap it here, pull it here. Alright? तो सबसे पहले नी कैप को अंदर की तरफ लाया, then we put one more tape on top, medially उसको लाने के लिए, and we do one more side on this side, V shape का, simply we get it in, strap it, tighten it, so knee is in. तो हम लोग सबसे बड़ा गलती क्या करते हैं इसके बाद पैर को खड़ा कर देते हैं. So we are not supposed to do it. कैसे करेंगे weight bearing check? पहले हम लोग leg check करेंगे, उसको बोलेंगे knee मोड़ो. Is it fine? Yes, it's not going outwards. This is fine. ये भी ले लो, ये पाँव भी. And
tell him to bridge करो, इसको उठाओ बीच में से. What is this?
Bridging.
Partial weight bearing. आधा weight यहाँ आ गया, आधा इस पाँव पे, आधा इस पाँव. कुछ हो रहा है नहीं, it's fine, I'm comfortable. So you can go ahead with one leg bridging. Now do one leg bridging. I'm fine, nothing is happening. Get on the toe, थोड़ा पीछे ले लो. अब आ जाओ, bridge करो. अब toe पे आ जाओ, इस पाँव के toe पे आ जाओ. हाँ. So push it harder. See, it's fine. Now the situation comes. कि ये पहले भी हो चुका है क्या? He is telling you, हाँ सर पहले भी हो चुका है. It's fine. अगर तुम्हारे में knee cap है, knee cap पहन के करो. सर पहली बार हुआ है. Talk to coach. कोच को पूछो जरूरी है क्या खिलाना? नहीं जरूरी है. Take him inside, give him a rest. Treat करो इसको. Strengthen the quadriceps. मैं आपको दिखाऊंगा इसका specific exercise क्या है. Make sure you do that quadricep exercise with him for 3 days and then do the squatting. कभी भी पहले directly squatting में मत डालना because we don't know what is the damage inside. Okay? अब उसके लिए आपको MRI कराना पड़ेगा. उसके लिए आपको X-ray में तो जाएगा नहीं, MRI कराना जरूरी है. Clear? समझ आया? No question? कर पाओगे? कितने लोग कर पाएंगे? करेंगे सब, बट इसको प्रैक्टिस करना है. जो भी आपने यहाँ सीखा है, इसको मुझे लगे 30 साल इसको करेक्ट करने हैं. ठीक है? आप एटलीस्ट 2 साल से 3 साल ले लो और इसको प्रैक्टिस करो. क्या नाम है आपका? अनिल सिंह के लिए एक क्लैप बजाओ. Anil Singh must have felt, Anil Singh must have felt कि क्या कर रहे हैं हम लोग, right? हम लोग क्यों बोल रहे हैं आप मॉडल बन जाओ? Because आप उसको फील करो कि क्या किया मेरे साथ, कहाँ पुश किया, कहाँ टाइप किया, कहाँ टेप बांधा. So जब भी आपको अपॉर्चुनिटी मिले ना, तो टेबल पे चढ़ जाओ, सर या मैम को बोलो मैम मेरे ऊपर दिखाओ. Alright, and I request registrar sir not only chocolate, इनको 10 marks इस एग्जाम में 10 marks इनको एक्स्ट्रा दे.
सबसे पहला कुछ उसी बात से स्टूडेंट्स को अभी भी सीख के ज्यादा मार्क्स ही पसंद है.
Now see this injury.
So Academe has to be carried off the court. Now, what did she grab? Did she grab the inside of her knee? It seems to be the.
कब करते हैं इस इंजरी को डायग्नोज हम लोग? आप अगर मैच में हो तो इस इंजरी को कभी डायग्नोज करते हो आप ड्रेसिंग रूम से करोगे, ग्राउंड पे जाके करोगे या एग्जामिन करके करोगे? कितने लोग बोलते हैं एग्जामिन करके डायग्नोसिस होता है? अगर मैं बोलूं कि मैं ड्रेसिंग रूम से डायग्नोज करता हूं तो क्यों? जब स्पोर्ट्स में जो आप बनोगे ना, आप अंदर सो नहीं सकते हो, राइट? आपको हर एक मूवमेंट देखना पड़ता है प्लेयर का, और जब ये इंजरी होती है तो आप डायग्नोसिस कहां से करते हो? ड्रेसिंग रूम से। और आप सोचते हो पहुंचते पहुंचते वहां तक कि एंकल इंजरी है, जब आप चेक करते हो तो ये नी इंजरी होती है। आपका डायग्नोसिस कभी भी राइट नहीं हो सकता क्योंकि आप ड्रेसिंग रूम से देख रहे हो, बट आपका जो कंसंट्रेशन है वो आपके गेम और प्लेयर पे होता है। इसलिए हम लोग बोलते हैं हम लोग डायग्नोसिस गलत कहां से करते हैं? ड्रेसिंग रूम से, और ठीक होता है ग्राउंड पे। एग्जामिन करने के बगैर आप डायग्नोज नहीं कर सकते। तो लेकिन हमारा कंसंट्रेशन हमारी गर्लफ्रेंड पे नहीं होता, हमारी फैमिली पे नहीं होता, हमारे बॉयफ्रेंड पे नहीं होता, हमारा कंसंट्रेशन रील्स पे नहीं होता, फोन पे नहीं होता, कहां होता है? इसलिए फोन आर नॉट अलाउड इन द ड्रेसिंग रूम। पहले हम लोग नहीं, तो जब हम लोग होते थे स्टार्टिंग में तो अंदर बैठ के फोन पे बैठे रहते थे, फोन नहीं था तो लेटते थे खाना खा के, राइट? अब वो टाइम नहीं रहा, आपको हर मिनट हर सेकंड डायग्नोज करना पड़ेगा। ओके, these are the first things you need to remember. Diagnosis, उस डायग्नोसिस से आपको एक और फायदा होगा, जब आप क्लिनिक पे बैठते हो तो कोई पेशेंट अंदर आता है डोर खोल के, तो आप तब भी फोन पे नहीं बैठोगे, आप उस पेशेंट को देखते रहोगे। तो जब आप वो ड्रैग करके पाँव ड्रैग करके चल के आता है तो आप उसको बोलते हैं एंकल में प्रॉब्लम है कि मेरा चप्पल फट गया, राइट? लेकिन मेरे बैक में पेन है, बट लेकिन आपका कंसंट्रेशन उस पेशेंट के ऊपर होता है, आपका डायग्नोसिस भी 99% ठीक। So the main thing is to concentrate whether you are diagnosing it, whether you are watching it. Clear? I think आज के लिए नी प्रैक्टिस करो आप, नेक्स्ट टाइम मैं एंकल दिखाऊंगा, बाकी भी स्पीकर्स हैं उनको भी बोलना है, बहुत ज्यादा लंबा चलेगा। I'll show you. आपको लगता है ना आप जिंदगी में क्या कर सकते हो, आपके बारे में क्या बोला जाता है, so I'll show you small video, ताकि this is basically more of an inspirational video. I am from Kashmir. I have slept first 2 nights on a street of Mumbai on Ajiri bed. I didn't have a place to stay. And हर कॉन्फ्रेंस में हमारे प्रेसिडेंट बोलते हैं सबको कि एजाज ने 6 साल में BMW खरीदी. But that is when I started working 4 o'clock in the morning and end up my day at 11 o'clock in the night. और आज भी वही रूटीन चल रहा है. मेरा कल भी सर ने टिकट रखा है सुबह 6 बजे का, कल सवेरे भी मुझे 4 बजे से ही निकलना है। सो अगर आप अपनी लाइफ को डिसिप्लिन करोगे, यू विल रीच द हाइट्स। लेकिन अगर आप रात को 12-1 बजे तक रील्स देखते रहोगे, इट्स इम्पॉसिबल टू गेट अप अर्ली मॉर्निंग, इट्स अफेक्टिंग योर होल लाइफ, होल सिस्टम। सो ट्राई टू स्लीप अर्ली, रेस्ट इज मस्ट। रेस्ट नहीं करोगे तो आपकी बॉडी को एनर्जी नहीं मिलेगा नेक्स्ट डे। ऑलराइट, करोगे आज से? क्या कितने बजे सोओगे? 10 बजे। 8 बजे तो नहीं हो पाएगा, 10 बजे ठीक है। ठीक है, अगर आप 10 बजे सोओगे तो आपको BMW मिलेगा, अगर आप 8 बजे सोओगे तो लंबोगिनी मिलेगा।
Just as I said, we came to us and you actually gain new experience. Just took one session, it was ripples.
Dr. Eza, who has been with us and has been always a great help whenever I'm in pain. Welcome, I will thank you and I will help you. We will be continuing to work hard on the right responsibility and suggesting that we get right after exercise and recently events. Okay, just aside, for a wonderful healing touch. I believe in the power of physiotherapy and wish you all the best. The recovery and hospital public health management and interaction has been a great and very well way of handles anything or any full set of muscle very next year of physiotherapy is one of the best and is one of the nicest activities out there. Every day they very
That's been a journey of 30 years. We have taken it step by step. Why I'm showing this is not because I want to tell you, okay, मैंने किया है. यहाँ पे कोई भी जा सकता है, कोई भी हम में से कर सकता है. But it's only remember that एक चीज मैं भूल गया, we need to be in our limits. हम लोग ऑर्थोपेडिक सर्जन नहीं हैं, न चैलेंज कर सकते हैं. हम लोग न्यूरो सर्जन नहीं हैं, न चैलेंज कर सकते हैं, न वो हमको चैलेंज कर सकते हैं. हम लोग फिजियोथेरेपिस्ट हैं, हमारी लिमिटेशन फिजियोथेरेपिस्ट की है. हम अपनी लिमिट पे काम करेंगे. वी आर द बेस्ट. जहां आपने ब्रेन में घुसने की कोशिश की और नी में ऑपरेशन बोला करते हैं, प्रॉब्लम्स वहां से स्टार्ट. आप बोलो मैं फिजिकल थेरेपिस्ट हूं, मुझे पता है मुझे फिजियोथेरेपी में क्या करना है, मुझे सर्जरी में क्या करना है मुझे नहीं मालूम, वो आपका काम है. बट आई हैव अ नॉलेज कि सर्जरी में कौन सा ग्राफ्ट आपने यूज किया. आई शुड नो दैट. अगर आप ACL सर्जरी को ट्रीट कर रहे हो, यू शुड नो ये क्वाड्रिसेप्स ग्राफ्ट है, रेक्टस फेमोरिस है या ये हैमस्ट्रिंग ग्राफ्ट है. उस हिसाब से आपका रहम हो, राइट. बहुत सारी चीजें सीखने को मिलेगी. यू हैव टू गो स्टेप बाय स्टेप एंड दैट्स हाउ वी रीच टू द हाइट. और मैं चाहता हूं कि नेक्स्ट टाइम जब सर कॉन्फ्रेंस करें यहाँ पे, आप में से एक ऐसा हो जो यहाँ पे एक स्पीकर बन के आए. देन इट्स वर्थ कि हम लोग आपको यहाँ आके स्पीच देते हैं. एंड रिमेंबर व्हाट वी से, ये कोई गीता पुराण या बाइबल में नहीं लिखा है. दिस इज द एक्सपीरियंस व्हिच वी आर शेयरिंग. कल को आपको बाहर जाके ये नहीं बोलना है कि माधवी मैम ने ये बोला, रिचा मैम ने ये बोला, सर ने ये बोला, डॉक्टर ने ये बोला. नहीं, हमने तो अपनी एक्सपीरियंस शेयर की. इससे भी अच्छा आप कर सकते हो और बोल सकते हो उसके बारे में. ऑलराइट. तो हम जो एक लास्ट चीज बोलूंगा आपको. अभी रिसेंटली ऑर्थोपेडिक सर्जन की कॉन्फ्रेंस हुई थी, तो उन्होंने मुझसे यही क्वेश्चन पूछा. उन्होंने बोला सर आप क्रायो के बारे में थोड़ा एक बोल दो. So they were top most orthopedic surgeon, Dr. Anand Joshi, Dr. दिनशा पारीवाला, आपने नाम सुना होगा, जिसने अभी मैक्सिमम सर्जरीज की है स्पोर्ट्स और Said, Ijaz, why physio? Why not orthopedic surgeon or anyone physician? Why physio on ground? I said, sir, next simple sir question पूछता हूँ, what is the first sign of injury? मुझे बोलना. What is the first sign of injury? अगर injury तो क्या कैसे पता चलेगा? हाँ, बुक पे क्या लिखा हुआ है? स्किन का कलर चेंज होता है ना. अगर मैं यहाँ मारूंगा तो क्या होगा? लाल हो जाएगा ना स्किन. तो मैंने उनको बोला सर ये गलत है जिसने भी लिखा है. कि practically when I was in Mumbai Indians team, Australian player injured हुआ, उसका स्किन पहले से ही लाल था. हाथ लगाने 47 डिग्री टेम्परेचर में खेल रहा है तो लाल तो होगा ही. At the same time, we had West Indian player David Bravo. He got an ankle sprain, hairline fracture on the ankle. मुझे दिख ही नहीं रहा, कलर तो ब्लैक ही उसमें. मैं कैसे बोलूं कि ये साइन है इंजरी का? I said ये बुक में लिखा है, किसी ने उसे गलत नहीं लिखा है, बट इसको लेके नहीं चल सकते. ठीक है, तो बेसिक्स बुक से ही मालूम पड़ेगा. प्रैक्टिकल से आप अपनी एनहांस कर सकते हो नॉलेज को, लेकिन बेसिक्स आपको बुक पढ़नी ही पड़ेगी. ऑलराइट, दैट्स एनफ फॉर टुडे.
Thank you, sir, for that engaging and informative session. May I request Dr. VC sir and VP Gupta sir for felicitation of Dr. S.R. Nashi sir. From here, we continue our journey. Another fascinating theme session. It is a pleasure to introduce Dr. Thyagarajan Subramaniam, MPD, PhD, Professor of Cardiopulmonary Physiotherapy at Lovely Professional University, Punjab. With over 20 years of experience in clinical practice, teaching, research, and academic leadership, he has built an impressive career in the field of physiotherapy. Please give a huge round of applause for welcoming Dr. Subramaniam.
Okay, good evening all. So, I think it's very, I'm assuming time. Of course, I'm going to play game now. So, sir has told about how the game makes his life change. Okay, so, but we are going to play a game now. Okay, only students, please stand up. A small game, only students. Just for refining your brain, this game can be helpful to you. At the same time, you are going to feel. You are going to feel the water. What sir says, the symptom was just observation. So I am going to make you to feel the symptom. Okay, ready? So all of you, just keep your left hand up and keep your thumb on your left, index finger on your right. Okay, take a deep breath. Take a deep breath and pinch it. Just pinch it. Don't breathe. Then start stamping the set. Stamping the feet. Just stamping the feet. 1, 2, 3, 4. If you feel, you can sit. If you feel uneasy, you can sit. 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24. If you feel uneasy, you can sit. 25, 26, 27, 28, 29, 30, 31, 32. Don't bluff. Okay, thank you. So of course everybody feel now what is symptom it is. What symptom it is? What is that? Do you remember the situation? When it was? When it was happened? Second wave. I don't want you to say our neighboring state is struggled. I think how many of you watched the web series of Train Man? Huh? I think Train Man. Madhav का बहुत अच्छा web series है about the Bhopal family. Okay, do you think there is a link between these situations? Okay, when the people not aware of that, they are going to die in next 10 years. That too without the same symptom what you have felt at the 30 seconds of breathlessness, and they are going to die. Did you ever see the floor of Rajasthan houses? Did you ever see your floor in your home? Did you feel the cold floor? What is the name of the kind of the material? Marbles. Famous for very beautiful marbles exporting all over the world. Do you know the story behind the marbles? How many people they don't know that they are going to die within 10 to 15 years by the disease? Anyone remember? Silicosis. The silicosis is one of the bad sign of the quarry that where they used to grind the stones and polishing the marbles that we are using to. Okay, my speech never be miss the emotional part of the education. What the country needs, what the state needs, what the people needs. Okay, you are the one. Whether you are going to get an award or reward, whatever it is. But when you are going to see for to whom you are going to work. Okay, so why you are going to work? So why do you focus on your aims? Of course, I am not anything going to be just like misguiding anything. So what I just want to tell you, so there are some of the areas that we are going to explore, not explore. That's the main point what I am trying to always convey in my presentation. Okay, so everybody is interested in training their body, but they less focus on training their lungs, training for the brain. Even we cannot hold for 30 seconds of your breath, how can you can reach the heights? Okay, here not only you, your players, your patients, whosoever is training. Okay, so my part is, so I am going to focus on the endurance part of the people as well as the sports athletes. Okay, so many of the people who have come across with the various training, but they miss one training is respiratory muscle training. So there are the intention was, I'm not just telling whatever I have, what read in the books or read in the websites. I explored. I spent 6 hard, painful years for my PhD to develop my device of respiratory muscle trainer. I have used the Tesla principle with the help of SSP. I'm very happy to present this idea because the engineering marvel I just used for a medical purpose for the Tesla principle in my own patented device which I have done for the last 6 years of my PhD. Okay, that's why I just want to say, I just want more people to come forward for more research, and even I spoke to PC sir about the collaboration to develop more and more patent and research in innovations in physiotherapy. Okay, so without that, I just want to explore the various part of the area. So why we have to train. So now you are going to feel the symptom of difficulty in breathing. So you have identified, yes, my endurance is low. If you are not able to go for a long walk, you are not able to do it. People are used to their vehicles, they used to travel by cycles, not even nowadays go by car, so then they never used to go by foot. Okay, so this is the main thing what we are lacking it. We have to focus more on the training methods. So we have many methods are used, and specifically inspiratory and expiratory training methods. Of course, both needs to be analyzed. So depends upon the situation of the patient. So basically, we train the muscles for the purpose of building the muscles, showing off the muscles. So where people use the bodybuilding. So similarly, but we never know about that. So what will be our efficiency in performing? So we don't know how to assess those things. So that's why your respiratory muscle various type of breathing method strategies, which I have mentioned in the morning also. You can apply on the stroke patient. Use a multidisciplinary approach. Apply on the stroke patient how the breathing affects, breathing pattern disorders. You can apply on your core stabilization exercises along with the breathing. Breathing can correlate with the back pain. You can, if you correct the breathing pattern, you can correct the back pain also. So there are the areas where we are going to train the muscles of the breathing. So that's the most important thing to prevent the fatigability of the respiratory muscles. So basically, when we are focusing on the different part of the training methods, so we focus on the people with the unilateral paralysis, especially for the stroke patients. So we always prefer for the other method. So how many times a patient is able to count the number without the breath? Okay. So you can also ask your patient. So try to count that 1 to 15. So how many times they are giving a pass in between 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. If they say correctly, the simple thing is how we are going to assess the fitness of your patient, especially for the neuromuscular diseases, spinal cord injury patients. So where they are focusing on. So we can identify various tools to measure their fitness level by simple verbal methods also. Yeah, talk test. We can use a talk test. We don't require to go for the pulmonary function testing for vesicular diseases and other diseases. So we just go with the simple method to analyze the fitness level of an individual. There are a lot of things are available and the resources and research evidences. So one is the talk test. Simple talk test also can identify a patient having with the loss of fitness of the lungs, especially for the lung fitness. So when we are going to now, how many of you feel uneasy or sometimes slight dizziness on the head when you are doing the same activity of with the stamping the leg? Anybody feel that? The same kind of the feel if the patient gets when they normal they get. That means you have to check for their vital signs immediately before further moving to the exercise protocol. So because what happened during exercise, it was not only you are going to increase the exercise intensity, also you are going to increase the ventilation, and through that the muscle work is also going to be increased. So every work has been increased. So when your heartbeat also increases. Okay. So I just want to give you some case scenario how you have to check for your heart before you are going to give some prescription of exercises. Of course, the ECG will be explained later by Dr. Mehul sir. So I just want to give you one case scenario also over there. Okay, what are the benefits of using the? So what is the principle behind this? So because whenever we are going for looking for the injury, so we have the irritation. Okay, and first initially we have the swelling for inflammation. So like that. So what happens when a person is having a lack of the endurance in the respiratory muscle when they work hard, when they run? When a person who runs, you know, the fastest man of the universe. You know who is that? Still Usain Bolt is the fastest man of the universe. His record is 9.83. Okay, if I'm not wrong, 9.882 seconds for 100 meters. Okay, so that is an unbelievable achievement. So how it is possible? Because of he has a very strong attenuated metabolic reflex. Whenever you run, the muscle requires to stop when you are getting pain or when you stop. So what happens when you are run? So the muscles, the respiratory muscles, will be pulled with the blood rather than the muscles of the legs. That's why the people who are having a good metabolic reflex, so we can achieve like a Usain Bolt. Okay, so this is the one thing what I have faced in my practice, my PhD study. So what we are missing, what Indians are missing, what Asians are missing. So we are all competing each other. But when we go for the Olympic, because we don't have the equal lung capacity among the Asians and Americans, British, they naturally have upper hand. Then how we can fight with them? And we are fighting with, we don't get gold medal. Yes, we can get the gold medal. I will show how. We are not focusing on this metabolic reflex. So the metabolic reflex activation, how it is going to be achieved? So using with the respiratory muscle training, RMT. RMT may be a small word, small thing, a small device I am going to show you right now. This can be, but it makes a great difference in your lung function. So these are all the various small tests can be performed after your metabolic reflex is increased or not. You can check your endurance also with doing all these tests which we are performing in our research lab in NTU. But anyone can do. I don't think so. Anyone can do. If the patient is having some problem, when you are using dry needling, sometimes the patient gets unusual symptoms. When dry needling, first initially you are identified, is there any problem in the lungs? So just simple examination, chest expansion, measure the expansion. Okay, what happened if you dry needling, if you are giving to upper trapezius? We must be very careful. Okay, I hope dry needling is one of the technique. Okay, everyone aware of the students, maybe second and first years. Yeah. So this is one of the very finest technique, but very dangerous technique also. If you miss, okay, if you're not properly pinching, if you're not keeping the patient prone line, you will be going to kill the person. Okay, so pneumothorax, the condition is called pneumothorax. We can examine also for any kind of situation when you are going to. So, and in what way you are going to kill the patients? By doing exercise, how can we kill the patient? Yes, we have to think negatively also. How do you kill the patient? THR patients. Total hip replacement. We just simply make them to mobilize joint. But we don't bother about the emboli. A small emboli can kill the person just moving a joint. Okay, so like this, the alertness which we can always focus. Of course, stroke patients. Stroke patients, even if you are going to use for the patient who are having a patient with DVT, if you are mobilizing it, then without seeing the signs and symptoms, same Watson said, if Africans cannot able to identify with the color of changes in the calf muscle, you cannot see. Same redness and swelling, same symptom. Okay, so it's not even for sports injuries, on the calf injuries, may kill a person. Okay, and another one very bad situation. Of course, luckily we have lucky athletes, less population in India, hypertrophic cardiomyopathy. I hope sir will be covering that also, I guess. Hypertrophic cardiomyopathy may go for sudden cardiac death. European soccer was famous, but sometimes sad. No more injuries, no more chance, no more reviving of the life. A celebrity sports person will die on the floor. Just imagine, the people cry like anything. European soccer, people are crazy about the game and crazy about their player also. The team players also. If one person lose Ronaldo, just imagine. But behind that, you are going to be a savior of them if you are not able to identify the cardiac part of these sports players. That's why we just need to focus on this. That's why what we are advising our students, we encourage our students to get a portable ECG device, and this is a mobile-based ECG device. So, and we take them every time before and after exercises. We take measurement of ECG and check for the lead to, of course, rhythm strip. So, which we are going to assess every patient, every player before and after the training. Okay, and we are going to check the HRV, the measurement test, which we are going to test for the variability of the heart rate. Okay, this is actually our players who are performed with the on the spot, having a slight difficulty after doing a rowing for 1.5 kilometers, and we got little stressed, and we did on the spot very tight, and we checked within 3 minutes the patients recover, the HRV also normal, and heart rate become under the control. So patient one, the player was safe. Okay, so many things we can work on. And what's the point? You just only look for the wording from the cardiologist or neurologist or orthopedician. Now the technology is in your hand. So it's your call whether to use or not. It is a matter of how they can measure the tool, very simplified tool to measure the ECG on the field. Okay, so before going to train any kind of the training with a sports player or any other person, so I can just prefer some of the basic assessment what I have mentioned about the submaximal test, and this is compulsory patient required for the. Okay, I'm lost. I'm just going to finish with one of the virtual learn how to virtual ventilation. How we are going to learn some of the technology in ICU, especially ventilator. How ventilator and respiratory muscle training parallel you are going to use it. All similar parameters. I just have just able to know all the settings in the ventilator. That also makes you to in this parameters. For example, let's just click on this the lung symbol. You can see here. Yeah, it's a manual breath key. Whenever the patient will start breathing, this key will be helpful to allow the manual breathing. So, like a lot of facilities, like running, just like running a car, driving a car. Okay, how we are using technology. Same way the virtual methods of ICU also given by digital training methods. And this is another one device. I just want to show you this. So we'll be we are teaching in this way only. We are teaching rather than just showing the books and also in the online sources. So we try to give a simulation before training for the ICU rehabilitations. There's different types of the ventilator, and there are multiple. So Nana is waving the hand there from there. So I respect for her, but she won't, because I travel 13 hours in 48 hours from Punjab by road and train track. So I just want to share. So students, you know that remember always we are having a discord in our lungs. Our entire lung, if you split out, it is including alveoli. Your lung is about the size of the tennis court. Okay, so just remember this one. So before you are going to plan any kind of the training strategies, and do not forget, look at your lungs and heart always. So I just want to show the some of the devices which it was inspired me why I should develop my own device. Okay, before I am going to start my PhD. So these are all the devices on the market. So and I have developed the device the cost of only 500 to 700 rupees. Now all the products available are about 3,000 to 25,000 for the single user, not one time use, single user only. Because so respiratory trainers we cannot share with everyone. So that's the main important thing what we have focused on your research, and of course what we have come across with our achievement. So we have developed the students with the main purpose of sharing this particular achievement from our university, and my student regularly says he works for the Olympian Neeraj. He's still working for the javelin throw expert. One of the gold man who clinched the gold medal for first gold medal in javelin throw in 2020 Tokyo Olympics. And of course, these are all our student is the personal physio for you, and also these are all the other big players from the NPU. So we have nearly about 11 hockey players who won the bronze medal in those particular Olympics, and also a few of the silver medals from the walking, wrestling, and other weightlifting. Also, 13 NPU students have achieved this mark. So believe it or not, if you are going to train your player or athletes in all ways, if you train your players, definitely you can give the remarkable players in your life. And I hope this can contact me anytime. So I hope already they are planning for the MOU between your university and our university. So very soon we will work more together on joining friends. Okay, thank you very much.
Thank you, sir, for that insightful presentation and all the knowledge that you have shared with us. Now I request Honorable Vice Chancellor Sir and Dr. B.P. Gupta to kindly come forward for the felicitation of Dr. Subramaniam.
stop talking amongst one another. We can also get somebody.
Ladies and gentlemen, we are moving closer to the final stretch of our scientific program, but there is still much more to discover. Let us take a moment to welcome a distinguished name in the field of cardiopulmonary physiotherapy, Dr. Naval Contractor, PT PhD scholar, with over 15 years of academic experience. He is the director and founder of Himalaya Multi-Speciality Hospital and Geriatric Hospital. He has also served as Dean of Academics at P.N. Patel Medical Campus and as a member of the Board of Studies at PNSG Gujarat. Please, sir, come on the stage to praise the field.
Good evening, one and all. आवाज नहीं आ रही। Can I request the students sitting back? Can they come front? Please आ जाइए. It's a request. Students sitting back, please come front. इधर बहुत सारी जगह खाली है. See, why I'm telling you is, students, please आगे आ जाइए. Those sitting back, please fill this space.
सामने जगह है, पीछे क्यों बैठे हो? सामने आओ, सामने आओ, सामने आओ. This side, sit at the front. अरे आप लोग सामने आओ,
Those
सामने
students,
आओ.
please come forward.
सामने आओ.
Please. See, why I'm telling you is, students, listen.
सामने और पीछे से सामने आओ, please. Lot of seats are there. At least last bench पूरा सामने आ जाओ. Last bench, please come to the front. Lot of spaces are there.
The reason behind that, why I'm asking you to come front, I'm going to show you few of the emergency ECGs. Do you understand emergency ECGs? If you are not going to recognize, the patient may die within 30 seconds. Within 30 seconds. So those ECG we are going to see, we are going to identify, and we are going to diagnose. तो पीछे बैठ के आपको definitely नहीं दिखने वाला. So that is the reason I'm asking you to come front. okay. It's okay. It's okay. It's okay. Don't take stress. My presentation will be English, Hindi and English both. ठीक है? ये presentation conversation रहेगा. ठीक है? मतलब आप भी कुछ बातें करेंगे, मैं भी कुछ बातें करूँगा, and we'll learn something. Right? ठीक है? And since morning what I come to know that majority students are first year, second year. Right? ठीक है? तो अब मैंने सोचा था कि कुछ अलग तरीके से presentation लूँगा. बट अभी उस तरह से लूंगा कि जैसे कि मान के चलो आप 12th पास हो गए हो. Understood? You have just passed the 12th and then you have entered into the first PPT. Okay, the language will be that is. Okay. So पूरे सेशन का कंक्लूजन ये है कि कुछ इमरजेंसी ECGs देखने वाले हैं और वो कार्डियोलॉजिस्ट या फिर वहां पे इंटेंसिविस्ट है या इमरजेंसी डिपार्टमेंट में जो रेसिडेंट डॉक्टर है इमीडिएट पेशेंट के सिम्टम्स को रिकॉग्नाइज करके तुरंत ईसीजी निकाल के कैसे शिफ्ट कर देता है उसको कार्डियक आईसीयू में या फिर उसको शिफ्ट कर देता है कार्डियोलॉजिस्ट के पास एंड देन दे गो फर्दर फॉर एंजियोग्राफी एंजियोप्लास्टी या फिर सीएमजी. ठीक, सो दैट वन ईसीजी वी हैव टू रिकॉग्नाइज. तो अगर ये थीम आज की जो है ना कार्डियोवास्कुलर थीम, ठीक है, सिंस मॉर्निंग वी हैव हर्ड द एन नंबर ऑफ सेशंस. मेरे सेशन की अगर बात करो जस्ट वन टेक होम अवे मैसेज कि ये ईसीजी को आइडेंटिफाई कर रहे हैं. ठीक है, एंड दैट इज व्हाट आई एम गोइंग टू टीच. अग्री? ठीक है, राइट? ओके, पीछे अगर ना दिखे तो आप आगे आ जाना क्योंकि स्मॉल स्मॉल थिंग्स आई एम गोइंग टू शो जो शायद पीछे से डेफिनेटली नहीं दिखेगा. अच्छा, इट्स देयर. ओके, थैंक यू. ठीक है, सी आई विल मेक इट वेरी क्विक एंड वेरी सिंपल. आप लोग देख सकते हो यहाँ पे पेशेंट है, डॉक्टर है, यमराज भी पीछे खड़ा है और पीछे भगवान भी खड़ा है. ठीक है, अब मान के चलो आप आईसीयू में, हाइपोथेटिकली सबको मानना है. ठीक है, आप आईसीयू में हो, वहां पे चेस्ट पीटी करने के लिए गए हो, पेशेंट का पीओडी 0 है, पोस्ट ऑपरेटिव डे 0, पेशेंट एक्सट्यूबेट हुआ है और कॉल आया है आईसीयू से कि पेशेंट को आके देख जाओ, उनकी चेस्ट क्लियर करनी. ठीक है, अब वहां पे पेशेंट के ईसीजीस, लाइंस, कैथेटर सब कुछ वहां पे चल रहा होगा. उस टाइम जब आप चेस्ट पीटी कर रहे हो, क्या आप ईसीजी रिकॉग्नाइज करके कर रहे हो? दैट्स द क्वेश्चन. आपको क्या लगता है क्या कर रहे हो आप? ऑफ कोर्स फर्स्ट ईयर सेकंड ईयर है तो आप अभी तक नहीं गए थे. ठीक है, इसलिए मैं आपको भी और एग्जांपल देता हूं. ठीक है, हाइपोथेटिकली अब मान के चलिए आप सब लोग बीपीटी क्लियर कर चुके हैं. हाइपोथेटिकली, ठीक है, हाइपोथेटिकली यू हैव टू अंडरस्टैंड दैट आप सब लोग बीपीटी क्लियर कर चुके हो, नंबर 1. अब पूरा 9 to 5 पूरा घर पे, मतलब जहां पे जॉब कर रहे हो, कॉलेज में हो, क्लिनिक में हो, हॉस्पिटल में हो, वहां पे 9 to 5 पूरा दिन पेशेंट देखा आपने. पेशेंट देखने के बाद आप घर जा रहे हो. घर जाने के बाद आप अपने फैमिली के साथ टाइम स्पेंड करते हो, डिनर करते हो एंड देन मी टाइम चालू होता है. व्हाट इज मी टाइम? इंस्टाग्राम, फेसबुक एंड स्नैपचैट. अब मान के चलो यू आर एट बेड. ठीक है, 10:30 हुआ है. हाइपोथेटिकली सब लोग सुनना. ठीक है, आर यू विद मी? यस सर. 10:30 यू आर इन योर बेड और एक नोटिफिकेशन आता है. सर आप सब भी सुनना, रात को 10:30 बजे नोटिफिकेशन आता है. वो नोटिफिकेशन अब हाइपोथेटिकली आप अज्यूम करो कि आपके बड़े पापा का. ठीक है, आपके बड़े पापा आपको एक मैसेज भेजते हैं. अभी कभी बड़े पापा आपको मैसेज भेजते हैं? नहीं. अब रात को 10:30 बजे आता है. सुनो, जैसे ही आप स्क्रॉल डाउन करते हो, बड़े पापा का तुरंत खोलते हो, देखते हो क्या? एक फोटो है और वो फोटो में है ईसीजी. एक फोटो है और फोटो में क्या है? ईसीजी. और नीचे लिखा है, बहुत प्यार से लिखा है, बेटा जरा देख के तो बता नहीं तेरे चाची का बेटा, जरा देख के तो बता तेरे चाची का है, क्या हुआ है? कब से उसको घबराहट हो रही है, पसीने छूट रहे हैं, वो बोल रही है अच्छा नहीं लग रहा है, चेस्ट टाइटनेस लग रही है। इमीडिएट हम नजदीक के एक हॉस्पिटल में गए, ईसीजी निकलवाया, उन्होंने कुछ दवाइयां तो दी, फिर घर छोड़ दिया। तो हमें तो सेटिस्फेक्शन नहीं हुआ, ठीक है, बट मुझे पता था कि हमारे घर में हमारी बेटी तो डॉक्टर है। हमारी बेटी कौन है? हमारा बेटा तो डॉक्टर है, क्यों ना उनसे पूछा जाए, राइट? तो आपको तो भेज दिया नोटिफिकेशन, सबको नोटिफिकेशन आ गया रात के 10:30 बजे। आपको क्या लगता है आप आंसर दे पाओगे? सर वी आर फर्स्ट ईयर बेबी, वी आर सेकंड ईयर बेबी, कैसे आंसर देंगे? आज आप डायग्नोस सीख के जाओ, दैट इज माय प्रॉमिस टू ऑल ऑफ यू। अग्री? आज आप डायग्नोसिस सीख के जाओगे, आप लोग मतलब समझो कि फाइनल ईयर को और इंटर को भी टक्कर दे दो कि ये इसीजी सर ये तो हमें आता है, ये डायग्नोस हमें आता है, ठीक है, राइट? सो रेडी? लेकिन यहाँ पे अब एक और स्टोरी थोड़ी सुनाता हूँ आपको। जैसे वो ईसीजी रात को आया ना सर, ठीक है, बच्चे लोग क्या करेंगे पता है? डबल टिक हो गया है, ब्लू टिक हो गया है, लेकिन रिप्लाई नहीं आ रहा है। रिप्लाई आएगा भी कैसे? ईसीजी देखना भी तो आना चाहिए। अब बड़े पापा जो है ना, वो चाची को बहुत शांत से बता रहे हैं कि बेटा रुक, अभी देख हमारी बेटी आंसर देगी क्या है करके। और हम क्या कर रहे हैं? एआई को पूछ रहे हैं, चैटजीपीटी को पूछ रहे हैं कि भाई जरा देख तो इसमें क्या है। दिस इज द सिनेरियो राइट नाउ, ठीक है, अंडरस्टूड? ठीक है, अब मान के चलो स्टोरी को थोड़ी आगे बढ़ा। अब ये सीरियस पार्ट, लिसन टू मी वेरी केयरफुली। अगर आपने बोल दिया चाचा ये ईसीजी नॉर्मल, और सुबह न्यूज आता है चाची चल बस, दिस हैपेंस। Then I cannot comment more on this, right? So serious part, अगर बाई चांस आपने बोल दिया कि ईसीजी नॉर्मल है और सुबह चाची का देहांत हो, the biggest blunder that one can ever make, right? ठीक है? और दूसरा बात, ठीक है, आपने बोल दिया कि चाचा ये ईसीजी बहुत सीरियस है, इमीडिएटली चाची को हॉस्पिटल ले जाओ, इमीडिएट, अभी क्या अभी, दिस इज वेरी सीरियस। और चाचा अपने वाइफ को तुरंत ही हॉस्पिटल लेके जाते हैं, मान के चलो मैक्स सुपर स्पेशलिटी हॉस्पिटल, अपोलो लेके जाते हैं, या एक्सवाइजेड एनी ब्रांडेड हॉस्पिटल देते हैं। और वहां पे जो इमरजेंसी डिपार्टमेंट में रेसिडेंट होगा ना, लिसन टू मी वेरी केयरफुली, वो बोलेगा काका किसने भेजा, सब कुछ नॉर्मल है, आपको इधर इमरजेंसी में किसने भेजा, सब कुछ नॉर्मल है। The matter of the fact is we do not know how to read ECG perfectly, and that is the harsh reality. That is the harsh reality. और ये डायग्नोसिस एक ऐसा डायग्नोसिस है, अगर आपने ठीक से नहीं किया, आपके पास पेशेंट आया है और अगर आपने ठीक से नहीं किया तो आप ठीक उसके यमराज हो, और अगर आपने ठीक से कर दिया तो आप कौन हो? This is the whole story behind this. Do you understand that? Yes, sir. Do you feel this? Yes, sir. ये कहानी आपके फैमिली की भी हो सकती है, आपके फादर की भी हो सकती है, आपके मदर की भी हो सकती है, आपके सिबलिंग्स की भी हो सकती है. So take it seriously. So this was the hypothetical case, but it's a reality, right? So see, bodybuilder दिख रहा है ये काका, ठीक है? हाँ, ये काका की एज 100 ईयर ओल्ड है, कितनी? 100 ईयर ओल्ड, ठीक है? अब ये काका आए थे चेस्ट पेन के साथ, ब्रीथलेसनेस के साथ, उनको बहुत सारा स्वेटिंग हो रहा था, चेस्ट टाइटनेस हो रहा था, ठीक है? He was not feeling comfortable. Understood? ये सारे सिम्टम्स सुने आपने? चेस्ट टाइटनेस, अच्छा नहीं लग रहा था, सांस लेने में दिक्कत हो रही थी, ठीक है? पसीने छूट रहे थे और बोल रहे थे घबराहट हो रही। आप लोग जब भी फाइल में देखोगे ना, सर माइट बी नोइंग दैट कि लिखा हुआ इट्स अ केस ऑफ घबराहट, ऐसा क्योंकि उनकी लैंग्वेज में भी लिखना है सब कुछ हिस्ट्री में, ठीक है? सो उनको घबराहट हो रही थी और ये रहा उनका ईसीजी। सर कुछ समझ में नहीं आ रहा है, यही आज हम डायग्नोज करते हैं। इट्स एन इमरजेंसी केस, यही आज हम डायग्नोज करके जाएंगे। अंडरस्टूड? राइट, ठीक है। तो इस ईसीजी को लास्ट में देखेंगे आप। ओके, जूम इन जूम आउट हो सकता है? इज इट जूम? I'll just I guess. Can you? हाँ, fine. So this is the ECG of that काका। वो लास्ट में देखेंगे उनको हुआ क्या, ठीक है? अभी थोड़ी बहुत डिटेल्स देख लेते हैं। यस, यहां पे आप सबसे ज्यादा ध्यान देना है। पीछे प्लीज लिसन टू मी वेरी केयरफुली। जहां पे भी समझ में नहीं आए मुझे रोक देना है यहाँ पे, क्योंकि अगर ये इमरजेंसी ईसीजी डायग्नोस करना है ना, ये पूरा इस स्लाइड है। अंडरस्टूड? राइट? तो जहां पे भी समझ में नहीं आए यू हैव टू होल्ड, राइट? चलो, तो सबसे पहला ये है नॉर्मल ईसीजी का क्यूआरएस कॉम्प्लेक्स 120 मिलीसेकंड का होना चाहिए या 0.12 सेकंड। सो पहला क्राइटेरिया क्या है? क्यूआरएस कॉम्प्लेक्स या तो 120 मिलीसेकंड या तो 0.12 सेकंड। बोलो तो एक साथ मेरे साथ सब लोग। फर्स्ट क्राइटेरिया इज क्यूआरएस कॉम्प्लेक्स। ड्यूरेशन क्या? ठीक है। अब सर ये ड्यूरेशन कैसे नापा जाएगा, इसका यहाँ पे है, ठीक है? देख यहाँ पे लिख रहा है आपको 1 mm is equal to 0.04 सेकंड, ठीक है? मतलब ये स्मॉल बॉक्स, दिस स्मॉल बॉक्स, ठीक है? दिस स्मॉल बॉक्स इज 0.04 सेकंड। तो 2 बॉक्स 0.08 हो जाएगा, 3 बॉक्स 0.12, दैट इज 0.12 सेकंड। अंडरस्टूड? तो अब मैं सेकंड के नहीं बॉक्स के बारे में बोलूं तो कितने बॉक्स होने चाहिए? 3। यहां तक मेरे साथ हो? आर यू विद मी? कंफर्म है? चलो, ठीक। नेक्स्ट, सो पहला क्राइटेरिया क्या है मेरे साथ बोलो? क्यूआरएस कॉम्प्लेक्स कितना होना चाहिए? ठीक है। अब ये क्यूआरएस कॉम्प्लेक्स जो है ना, PQRST, उसमें फर्स्ट ईयर सेकंड ईयर को पता है क्यूआरएस इज वेंट्रिकुलर डिपोटेंस, राइट? तो यहां पे मैं आगे नहीं जाऊंगा, वी हैव टू कट इट शॉर्ट एंड फिनिश इट फास्ट, ठीक है ना? ओके, सो फर्स्ट थिंग इज क्यूआरएस 120 मिलीसेकंड या 0.12 सेकंड होना चाहिए, राइट? ठीक है। दूसरा, अब यहां पे देखना है पे अटेंशन, ठीक है? अब कैन यू आइडेंटिफाई दिस पॉइंट? आप जरूर कर पाओगे सर, दिस पॉइंट। अभी जूम, बस चलिए देख, लिसन टू मी वेरी केयरफुली। जहां पे Q, R और S खत्म हो रहा है, आई रिपीट, Q, R, S जहां पे खत्म हो रहा है और जो कर्व चालू होता है वो पॉइंट है आपका J पॉइंट। सर PQRST पता था, J कहां से आया वही बता रहा हूं, ठीक है? जहां से आपका QRS खत्म हुआ वो फर्स्ट क्राइटेरिया, वो फर्स्ट पॉइंट क्या है? J पॉइंट। क्या है वो? J पॉइंट। क्या है वो? J पॉइंट। क्लियर है? अभी देख, ये J पॉइंट से अगर लाइन आगे जाती है तो वो कौन सा वेव बनाती है? T वेव। सबको बताइए, ठीक है? करेक्ट? ओके, अभी जस्ट नो, just now. ठीक, चलो। So when QRS is getting completed, the first point is the J point, और ये J point से आगे होता है आपका T वेव, ठीक है? तो ये जो रेड कलर जो मैंने मार्क किया है, ठीक है, वो है आपका ST सेगमेंट। क्या है वो? ST सेगमेंट। S यहाँ पे खत्म हुआ, J पॉइंट चालू हुआ और T वेव स्टार्ट हुआ, तो ये हो गया ST सेगमेंट। अब लिसन ऑल ऑफ फर्स्ट क्राइटेरिया था QRS आपका 120 मिलीसेकंड या 0.12 सेकंड होना चाहिए। दैट्स द फर्स्ट क्राइटेरिया टू आइडेंटिफाई ECG। जो इमरजेंसी जो आज देखने वाले हो उसका फर्स्ट क्राइटेरिया ये। दूसरा क्राइटेरिया ये जो ST सेगमेंट जो है ना, ठीक है, वो ऐसा कभी हॉरिजॉन्टल नहीं होगा। देखो कभी हॉरिजॉन्टल नहीं होगा, वो स्लाइटली अपवर्ड होगा। कैन यू अप्रिशिएट स्लाइट अपवर्ड है? यस सर। छोटी छोटी बारीकियां हैं, बुक में नहीं है। एज सर से ना हम आज आपको साथ एक्सपीरियंस शेयर, वी आर शेयरिंग द एक्सपीरियंस, दिस इज नॉट रिकॉर्डेड इन द बुक्स, अंडरस्टूड? सो ST सेगमेंट ऐसे फ्लैट, आप देखना आप अपनी फिजियोलॉजी की फर्स्ट ईयर सेमुलिंगम अगर बुक आप फॉलो कर रहे हो, कार्डियोवास्कुलर सिस्टम, ECG चैप्टर देखो ना, ऐसे सेगमेंट ऐसे स्ट्रेट है, आप देख लेना, घर जाके आप देख लेना। ST सेगमेंट कभी स्ट्रेट नहीं होता है, इट इज स्लाइटली इंक्लाइंड अपवर्ड। ओके, ये चीज याद रखिए। तो पहला था QRS, दूसरा था J पॉइंट, तीसरा था ST सेगमेंट, और वो कैसा होगा? स्लाइटली अपवर्ड। और ये अपवर्ड होने के कारण, लिसन टू मी वेरी केयरफुली, ये अपवर्ड होने के कारण और T वेव का बनने के लिए ये कौन सा वेव बन जाता है? कॉनकेव, कॉन्वेक्स नहीं। ये क्या बनता है? कॉनकेव। तो चार चीज मैंने आपको बताई। नंबर 1 अगर आपको लिखनी है तो भी लिखना है, लिख लो। नंबर 1 QRS आपका 120 मिलीसेकंड होना चाहिए या तो 0.12 सेकंड। नंबर 1 रिकॉर्डेड, नंबर 1। नंबर 2 J पॉइंट, नंबर 2 क्या है? J पॉइंट, जहां पे QRS खत्म हुआ वो फर्स्ट पॉइंट इज अ J पॉइंट जो बुक में नहीं दिया गया है। नंबर 2। नंबर 3 आपका जो ST सेगमेंट है वो हॉरिजॉन्टल नहीं होगा, स्लाइटली अपवर्ड होगा, और फिर T वेव चालू होता है, ठीक है? तो थर्ड पॉइंट इज दी ST स्लाइटली अपवर्ड, एंड थर्ड पॉइंट ST स्लाइटली अपवर्ड, and fourth point it is concave in shape क्योंकि T वेव चालू है। Are you with me all of you? Yes sir. ये चार चीजें आपको समझ में आई? Yes sir. Shall I repeat this? No sir. Good. ठीक है, so less than 120 J point, this is slightly upward and this is concave in shape। ये मैंने आपको नॉर्मल चीजें बताई कि हेल्दी इंडिविजुअल में दिखे। अगर आपको नॉर्मल पता पड़ेगा तो अबनॉर्मल पता पड़ेगा, राइट? सो ये नॉर्मल के बाद अब आगे चलते हैं अपने अबनॉर्मल के बाद, ठीक है? अभी देखो यहाँ पे पैटर्न्स ऑफ इश्चियम, ठीक है? ये आपको फ्लैट दिख रहा है कि कॉनकेव दिख रहा है? फ्लैट दिख रहा है कि कॉनकेव? दिस वन फ्लैट है कि कॉनकेव? बेटा ये फ्लैट है ना, फ्लैट है ना, ठीक है? एकदम फ्लैट है, कॉनकेव नहीं है। तो ये नॉर्मल हुआ कि अबनॉर्मल? ठीक है, ये फ्लैट है कि कॉनकेव के कॉन्वेक्स है? तो ये नॉर्मल है कि अबनॉर्मल? वेरी गुड। चलो ये वाला एकदम, चलो इसको छोड़ दो, ये वाला ये फ्लैट है, स्ट्रेट अपवर्ड है, कॉनकेव है, कॉन्वेक्स है, क्या है? तो नॉर्मल क्या अबनॉर्मल? वेरी गुड। चलो ठीक है, एंड दिस वन इज ओके, एंड दिस वन फ्लैट है, स्ट्रेट है कि डाउनवर्ड है? डाउनवर्ड। तो नॉर्मल क्या अबनॉर्मल? डाउनवर्ड। एब्सोल्युटली फाइन। तो ये कब पता पड़ा आपको? जब आपको नॉर्मल पता। कितने लोग को ये समझ में आया? वाओ, इसका फोटो लिया जाए। चल गुड, ठीक है? सो ये नॉर्मल पता पड़ा तो आपको अबनॉर्मल पता पड़ा, ठीक है? एंड आई टेल यू समथिंग, जो फैकल्टीज यहाँ पे कार्डियो से नहीं है ना, आई टेल यू आप भी इसी चीज डायग्नोस करके जाओगे सर, हाँ, दैट आई प्रॉमिस, ठीक है? सो नाउ हमको ये सब पता पड़ गया, अभी इसको मत पढ़ो कुछ, अभी सिर्फ इसके ऊपर ही जाना है। लास्ट में मैं आपको सब कुछ करा दूंगा और आप ये एक डिजीज के लिए मास्टर बन जाओ, ठीक है? अभी देखो जो मैं कब से बता रहा था, ग्रीन डिनोट क्या कर रहा है? स्लाइटली अपवर्ड कॉनकेव, हाँ या ना? कैन यू अप्रिशिएट, कैन यू जूम दिस? यस, थैंक यू। सो दिस इज नॉर्मल ग्रीन वन, J पॉइंट, उसके बाद ST इज स्लाइटली अपवर्ड एंड कॉनकेव एंड T वेव बन गया। बट अगर ये ऐसा स्ट्रेट है, ऑब्लिक है, अपवर्ड है तो वो अबनॉर्मल है, अभी हमने देखा, राइट? एंड अगर ये थोड़ा और अपवर्ड हो गया, कॉन्वेक्स हो गया, तो और भी डेंजर है, तो और भी वो एकदम अबनॉर्मल है, ठीक है, तो ये चीज अभी अपने को माइंड में रखनी है, शेप माइंड में रखना है। तो शेप सबको माइंड में आ गया है? कोई डाउट है? पक्का है ना? चलो नेक्स्ट। ठीक, हाँ, जब स्कूल में थे, फर्स्ट स्टैंडर्ड, सेकंड स्टैंडर्ड, थर्ड स्टैंडर्ड, फोर्थ, फिफ्थ, सिक्स्थ तक की बात करो, तब सबको हार्ट कैसा लगता था? ऐसा। कैसा लगता था? लेकिन जैसे जैसे बड़े हुए और फिर 11, 12 और बायोलॉजी में आए तो हार्ट ऐसा हो गया। धोखा हो गया आप सबके साथ। क्या हो गया? धोखा हो गया। पहले तो हमें ऐसे पढ़ाया गया था, अब ऐसे हो गया है, राइट? लेकिन जब आप अब बीपीटी में आ चुके हो तो आपको पता है कि अब हार्ट ऐसा भी नहीं है, हार्ट के लिए आपको ऐसा कुछ स्ट्रक्चर देखना पड़ेगा। Am I right or right? ठीक है, जो कब से मॉर्निंग में ये मैम इवोल्यूशन की बात कर रही थी, when cardio started and today what we are, ठीक है, the same way आपके जब चाइल्डहुड डेज थे तब हार्ट को क्या सोचा, स्कूल में आए बायोलॉजी लिया तब हार्ट के बारे में क्या सोचा, और अभी आपको हार्ट के बारे में क्या सोचा। ठीक है, I'll take 2 minutes, आपको कुछ समझना है। हार्ट खुद अपने आप को ब्लड सप्लाई देता है। फर्स्ट ईयर एनाटॉमी, कोरोनरी आर्टरीज, समझ में आ रही बातें है ना? मैंने पहले बोला था जैसे आप 12th पास करके आए वही लैंग्वेज में बात करूंगा। ओके, सो हार्ट खुद को ब्लड सप्लाई देता है। ठीक है, राइट साइड पे राइट कोरोनरी, लेफ्ट साइड पे लेफ्ट कोरोनरी। यहां तक क्लियर है सबको? राइट। अभी यहाँ पे आपको एक चीज देखनी है, इफ यू कैन अप्रिशिएट, कैन यू सी द राइट कोरोनरी? आप वहां पे प्रोजेक्शन पे देख सकते हो, पीछे दो पीपल सिटिंग बैक। ये राइट कोरोनरी राइट साइड पे जाती तो है, लेकिन पता है आपको मेजर ब्लड सप्लाई यहाँ पे इंफीरियरली देती है। नॉर्मली कर दो, हाँ, राइट साइड जाती तो है। यहाँ पे कॉन्सेप्ट समझो, कॉन्सेप्ट समझ में आ गया? डॉक्टर सर ने बोला था पढ़ाई पढ़ने के लिए मत करो, नॉलेज लेने के लिए करो, सक्सेस मिल जाएगी। ठीक है, हाँ, राइट साइड जाती तो है लेकिन मेजॉरिटी वो इंफीरियर पार्ट को कवर कर रही है। ठीक है, मेजॉरिटी वो कहां पे कवर कर रही है? इंफीरियर पार्ट, नंबर 1। नंबर 2, लेफ्ट कोरोनरी जो है ना, ठीक है, वो आगे आके 2 में डिवाइड होती है। कितने में डिवाइड होती है? 2 में। एक रास्ता जा रहा है, आगे जाके 2 रास्ते बन जाते हैं। क्लियर है? सो लेफ्ट कोरोनरी 2 में डिवाइड हुई, एक जो है वो बोलती है मैं सीधा सीधा नीचे आ जाऊंगी फ्रंट में, एंटीरियर, और दूसरा बोलती है मैं लैटरल साइड पे नीचे जाऊंगा। ठीक है, सो यहां पे राइट कोरोनरी आर्टरी है राइट साइड, लेकिन जा रही है इंफीरियर। लेफ्ट कोरोनरी आर्टरी कितने हैं? 2 ब्रांच। ठीक है, एक जा रही है फ्रंट में, ठीक है, उसका नाम है लेफ्ट साइड के, इसमें लेफ्ट, एंटीरियर आ रही है इसलिए एंटीरियर, और नीचे की तरफ जा रही है मतलब डिसेंडिंग, तो उसका नाम क्या पड़ गया? लेफ्ट एंटीरियर डिसेंडिंग। बोलो सब एक बार, लेफ्ट एंटीरियर डिसेंडिंग आर्टरी। वेरी गुड। और जो लेफ्ट साइड पे पूरा लेफ्ट तरफ घूम के आ रही है मतलब सर्कमफ्लेक्स, इट गेट्स सर्कमफ्लेक्स्ड, है ना? तो दूसरी आर्टरी का नाम क्या बन गया? लेफ्ट सर्कमफ्लेक्स। अब इसको एक एरिया के साथ कनेक्ट करना है, इसी से देखना है ना अपने को, तो अभी एक एरिया के साथ कनेक्ट करना है। क्या समझो, ये अगर राइट साइड जाके इंफीरियरली जा रही है, टेक माय वर्ड्स, वो इंफीरियर वॉल ऑफ द हार्ट को सप्लाई कर रही है। किसको सप्लाई कर रही है? समझ में आ रहा है? देखिए, इफ यू कैन अप्रिशिएट, इंफीरियर वॉल है हार्ट का, है ना? ठीक है, अगर ये एलईडी देखें लेफ्ट एंटीरियर डिसेंडिंग, तो आप सब बताओ कौन सी वॉल होगी हार्ट की? एंटीरियर, है ना? फ्रंट में है कि नहीं? और नाम भी उसी से बना, लेफ्ट एंटीरियर डिसेंडिंग। तो कौन सी वॉल को सप्लाई करेगी? एंटीरियर। आर यू विद मी? यस सर। तो ये इंफीरियर हो गया, ये एंटीरियर हो गया। आप बताओ ये कौन सी वॉल है? लेफ्ट। अंडरस्टूड? टू सम अप द होल स्टोरी, right coronary artery supplies inferior wall of the heart, then LAD, left anterior descending, supplies the anterior wall of the heart, and LCX, left circumflex, supplies the lateral wall of the heart. Are you with me? Yes sir. यहाँ तक क्लियर है? Yes sir. तो इस चीज देखने में बहुत मजा आएगा। ठीक है, चलो नेक्स्ट। हाँ, अभी पता नहीं कौन मॉडल है, बट समझते हैं। देख, अगर इनका फोटोशूट अलग अलग एंगल से लिया जाए तो उनके अलग अलग डायरेक्शन पता पड़ेंगे, लेफ्ट से वो कैसे दिखते हैं, फ्रंट से वो कैसे दिखते हैं, राइट से कैसे दिखते हैं, पीछे से कैसे दिखते हैं, ऑब्लिक एंगल से कैसे दिखते हैं। उसी तरह से अगर हार्ट की एक्टिविटी अगर हमें देखनी है ना तो उस हिसाब से अलग अलग एंगल से हमें लेना पड़ेगा। तो अलग अलग एंगल से फोटो लिए तो ऐसा दिख रहा है, देखो फ्रंट में दिख रहा है, ऑब्लिक दिख रहा है, ये ऑब्लिक दिख रहा है, ये भी ऑब्लिक दिख रहा है, ये बैक से दिख रहा है। सो उसी तरह से अब ईसीजी लीड्स पे मैं आता हूं। अंडरस्टूड? लीड्स इजी है, अभी समझ में आ जाएगा, फिर तुरंत हम ईसीजी देखेंगे। I'll take 5 to 10 minutes, not more than that, और ईसीजी डायग्नोस कर। ठीक है? रेडी? यस सर। चलो गुड। यस, यहाँ एक वॉलंटियर आ जाएगा फटाफट, यहाँ पे कोई एनीवन फटाफट वॉलंटियर, कोई भी फटाफट। चलो खींच के बुलाया उसको, नहीं आ रहा। चलो ठीक है, अभी देखो लीड्स के बारे में बात करेंगे। क्यों? क्योंकि वो लेडी का भी हमने देखा ना कि अलग अलग एंगल से देखना है तो हमें कैमरा तो सेट करने पड़ेंगे, राइट? उसके बगैर तो पॉसिबल नहीं है। तो हार्ट की अलग अलग वॉल को अब आइडेंटिफाई करना है हमें विद रिस्पेक्ट टू आर्टरी। अगर मुझे इंफीरियर वॉल को आइडेंटिफाई करना है तो कुछ राइट साइड पे लीड्स लगेंगे, एंटीरियर वॉल को आइडेंटिफाई करना है तो फ्रंट में लीड्स लगेंगे, लैटरल वॉल को आइडेंटिफाई करना है तो लैटरल साइड लीड्स लगेंगे। इज दैट क्लियर? मुझे इंफीरियर वॉल चेक करनी है तो इंफीरियर कुछ रहेगा, फ्रंट में कुछ चेक करना है तो फ्रंट में कुछ रहेगा, लैटरल साइड पे कुछ चेक करना है तो लैटरल साइड पे। सो इजी, ठीक है? तो अभी देखो हमारी चेस्ट लीड होती है V1 to V6। कितनी होती है? V1 to V6, ठीक है? वो चेस्ट पे लगाई जाती है। अभी फोटो में यहाँ पे मैं दिखाऊंगा अभी, ठीक है? V1 to V6 जो यहाँ पे ऑलरेडी देखी गई, ठीक है? चेस्ट लीड्स, अंडरस्टूड? ठीक है? इसके अंदर अभी क्या डिटेल है वो मैं आपको थोड़ी देर बाद बताता हूँ। दूसरी जो लीड जो मैंने इनको यहाँ पे बुलाया है वो है ये, तो हाथ से ऊपर कर दे, वेरी ठीक है? सो दिस इज AVL, लेफ्ट साइड है, हाँ या ना? ठीक है, तो ये क्या बन जाएगा? AVR, ठीक है? दिस इज AVL, लेफ्ट साइड का, दिस इज AVR, तो ये AVF, फुट, ये लेफ्ट, ये राइट और ये फुट। समझ में आया? कितने लोग समझ में आ गया? These are the augmented legs, AVL, AVR and AVF, राइट? ठीक है, ये 3 लीड याद रह गई और 6 जो चेस्ट की बोली थी वो, ठीक है? अब बाकी और 3 लीड है वो मैं आपको बताऊंगा, ठीक है? ठीक, नंबर 1 फ्रॉम राइट टू लेफ्ट लीड 1, राइट टू लेफ्ट लीड 1, क्लियर है ये? राइट टू लेफ्ट लीड 1, ठीक है? देन फ्रॉम द लेफ्ट शोल्डर टुवर्ड्स द लेफ्ट लेग, दैट इज लीड 2, left shoulder to left leg lead 2, and right shoulder and the left leg lead 3. Lead 1, lead 2, lead 3, anterior triangle जो आपने फर्स्ट ईयर फिजियोलॉजी में पढ़ा। डिटेल में नहीं जाएंगे, अभी सिर्फ लीड्स की पोजीशन में करा रहा हूं, ठीक है? टाइम होता तो आगे जाते, लेकिन अभी टाइम नहीं है तो फटाफट लीड्स बता रहा हूं। सो टोटल हमने कितनी लीड देखी? 12, 6 चेस्ट लीड जो यहाँ पे है, ठीक है? फिर यहाँ पे देखो, दिस इज लीड 1, लीड 2, लीड 3, करेक्ट? 1 from right to left, then left to foot, and then right to foot. So 1, 2 and 3, understood? और यहाँ पे देखा था हमने राइट साइड पे एवियर, लेफ्ट साइड पे एवियर और डाउन पे फुट। कितने लोग को ये 3, 3, 6 और 6, 12 ये समझ में आया? तो अब यहाँ पे एक कॉन्सेप्ट है, अब यहाँ पे एक कॉन्सेप्ट है जो फाइनल कॉन्सेप्ट है, अब इसी फाइनल, ठीक है? सो बच्चों अब यहां से ध्यान से सुनना, मान के चलो, लिसन टू मी वेरी, मान के चलो कि राइट साइड की कोरोनरी आर्टरी हमने देखी थी जो इंफीरियर वॉल में सप्लाई करती थी, याद है ना ये बात? राइट साइड की कोरोनरी कहां कहाँ पे थी? फ्रंट में, और एलसीएक्स कहाँ थी? लैटरल साइड। अब हमने सोचा था कि अलग अलग एंगल से कैमरे रखने हैं अपने को, ठीक है? तो ये लीड्स के हिसाब से कैमरा रख दिया हमने, कैमरा रख दिया। अब फोटो खींचनी है, तो खींच मेरी फोटो। गाना सुना है? खींच मेरी फोटो, मैं देखता हूँ तेरे में हो क्या है, राइट? अभी देख, लेट्स अज्यूम अगर पर्सन को मान के चलो कि LCX लेफ्ट सर्कमफ्लेक्स में प्रॉब्लम है, ठीक है? राइट साइड के फोटो कुछ कैप्चर कर पाएंगे? नहीं कर पाएंगे ना? क्या नीचे के फोटो कुछ कैप्चर कर पाएंगे? लेकिन लेफ्ट साइड के कर पाएंगे, हाँ या ना? तो लेफ्ट साइड पे अगर आप देखो तो एरिया था, हाँ या ना? लेफ्ट साइड एरिया था, राइट टू लेफ्ट लीड 1 थी, V5 V6 था, ये 4, ये क्या है? फिर से 1 कुछ कैप्चर करते हैं एक्चुअली मैंने कवर नहीं किया लेकिन बोल देता हूँ, स्टेमी मतलब ST सेगमेंट एलिवेटेड, एन स्टेमी याद है ना? ठीक है, तो आपको थर्ड ईयर में अभी आएगा, इसलिए मैंने कवर ही नहीं किया है क्योंकि यू आर फर्स्ट ईयर एंड सेकंड ईयर, तो मैंने स्टेमी एंड स्टेमी लिया ही नहीं। लेकिन ST सेगमेंट यहाँ पे क्या जा रहा है, शिफ्ट हो गया ऊपर, जो नीचे होना चाहिए था वो क्या हो गया, शिफ्ट। तो अगर ये AVF में है, लीड 2 में है, लीड 3 में, अप्रिशिएट कर पा रहे हो पीछे, आर यू अप्रिशिएटिंग, है ना? ठीक है, तो अगर लीड 2, 3 और AVF में ये है प्रॉब्लम, तो ये कौन सी वॉल्व हुई, इंफीरियर वॉल। कौन सी वॉल्व हुई, इंफीरियर वॉल। तो ये आर्टरी कौन सी हो गई, राइट कोरोनरी। तो ये ECG देख के जो कार्डियोलॉजिस्ट सीधा बता देता है कि इसको राइट कोरोनरी ब्लॉक है, वो आप फिजियो भी बता सकते हो बीइंग फर्स्ट ईयर, एंड क्लैप योरसेल्फ फॉर दैट। जो कार्डियक सर्जन सब, जो कार्डियक सर्जन और कार्डियोलॉजिस्ट और आईसीयू इंटेंसिविस्ट और एनेस्थेसियोलॉजिस्ट जो इमरजेंसी में होते हैं, जो वो लोग डायग्नोस कर रहे बच्चे वो सीख रहे हैं, एंड दे आर आंसरिंग दिस। हाउ ब्यूटीफुल इज दैट। चलो देख, इसमें तो आप अच्छे से आइडेंटिफाई कर पाओगे कौन सा ऊपर चला गया, ST सेगमेंट अपलिफ्ट हो गया, ऊपर चला गया। कहां पे दिख रहा है आपको, पहले लीड 1 देखो, लीड 2 देखो, 2 में कुछ हाँ या ना, दिख रहा है ना? तो अगर लीड 2 दिखी तो उसके दो भाई बहन कौन है, लीड 3 एंड AVF। तो देखो लीड 3 में दिख रहा है ऊपर उठा हुआ, देखो ये लीड 2 ऊपर है तो लीड 3 भी कैसी है, ऊपर उठी हुई है कि नहीं, राइट? ठीक है, तो 2, 3 तो उसके साथ क्या आएगा, AVF। तो देखो AVF का ECG देखो, बाकी सब देखो नॉर्मल है, देखो कैन यू सी V1 V2 V3 V4 देखो नॉर्मल है, बट ये देखो ये ऊपर उठ गए, ये ऊपर उठ गए, ये ऊपर उठ गए। Are you getting? So again it's a which wall, lead 2, 3 AVF, which wall, inferior artery, right coronary, very good। चलो इसमें चीख चीख के बता रहे मैं कहां पे उठा हूं, देखो चीख चीख के बता रहा है, 2, 3, 4, 5 कौन सा हो गया ये, एंटीरियर वॉल। और एंटीरियर वॉल मतलब which artery, लेफ्ट एंटीरियर डिसेंडिंग, करेक्ट? समझ में? ये आप मायोकार्डियल इंफार्क्शन आइडेंटिफाई कर रहे हो, क्या आइडेंटिफाई कर रहे हो, मायोकार्डियल इंफार्क्शन, MI, जिसके अंदर फिर पेशेंट का CABG होता है, डिपेंड्स, एंजियोग्राफी करके एंजियोप्लास्टी करना है तो ठीक है, और अगर सर्जरी करना है तो वो कितने लोगों को समझ में है? हाउ मेनी ऑफ यू आर विद मी? पक्का है ना? ठीक है, चलो इसमें चीख चीख के चिल्ला रही है लीड्स, देखो कौन सी है जो ऊपर उठी हुई है, V2, V3, V4, V5, again which border, which wall, anterior wall, which artery, left anterior descending। Are you getting now? Very good। चलो इसमें भी चीख चीख के बोल रहा है, कौन है कल्प्रिट, V2, V3, V4, V5, V6, दिख रहा है, मतलब एंटीरोलैटरल वॉल, समझ में आया? तो एंटीरोलैटरल मतलब एंटीरियर वॉल की पीछे कौन सी आर्टरी, लेफ्ट एंटीरियर से, एंड लैटरल वॉल की, तो इसका मतलब लेफ्ट में ही ब्लॉक हो सकती है, करेक्ट? समझ में आ रहा है सबको? डायग्नोसिस समझ में आ रहा है? चलो वेरी गुड। ये मत करो, पागल हो जाओगे। इसमें भी चीख चीख के बोल रही है लीड्स के, मैं ऑब्जर्व करूं कौन सी, V2 वेरी गुड, V3 वेरी गुड, V4, V5, V5 तो भी ठीक है, देखो क्योंकि कॉन्केव लेके ऊपर जा रहा है, समझ में आ रहा है? तो V5 भी ठीक है। सो ये सिर्फ एंटीरियर वॉल है, V2, V3, V4, तो ये एंटीरियर वॉल मतलब which artery, left anterior descent, very good। अब इसका बता, देखो अगर आप इसको करो दिख रहा है, लेकिन देखो मैंने क्या बोला था, फर्स्ट क्राइटेरिया क्या था, QRS कितना होना चाहिए, ये देखो 3 बॉक्स से ज्यादा है, If it is 3 box more than that और ECG में से दिख रहा है ये मायोकार्डियल इंफार्क्शन नहीं, भले ST सिग्नल एलिवेटेड क्यों ना, ये गांठ बंद करके रखना गले में, बाय मिस्टेक MI मत बोल देना, नहीं तो वो रेसिडेंट बाहर निकाल देगा आपको। So first thing first देखो, आगे में देखो QRS कैसे नॉर्मल है देखो, can you appreciate this? छोटा सा, can you appreciate? हाँ या ना? देखो कितना छोटा छोटा है QRS, दिख रहा है? इसके आगे का दिखाता हूँ, देखो ये छोटा है, ये छोटा है, ये छोटा है, ये छोटा है, स्मॉल, बट यहाँ पे देख ये 120 से बड़ा, तो ये फर्स्ट क्राइटेरिया में बैठ नहीं रहा है, इसका मतलब उसको आप हिस्ट्री में इंफॉर्मेशन में मत सोचो, नेवर एवर, अंडरस्टूड? कितने लोगों को समझ में आ गया ये? पक्का है? अब ये काका है जो पहले हमने देखे थे, बस हो गया, खत्म ही कर रहा हूं, कंटिन्यू कर दो, वो मैम मारेंगे मेरे को, नहीं मारेंगे, चलो आपको मजा आ रहा है? यस देन गुड। ये काका है, सबसे पहले देखे थे, उनको क्या प्रॉब्लम हो रही? ये काका को क्या प्रॉब्लम हो रही थी? राइट, और हमने सबसे पहले उनका ECG देखा था, तब हमें कुछ नहीं पता, मानते हो ना ये बात? अब इनका ECG देखें, वही स्लाइड मैंने रिपीट किए, अब आप इसका डायग्नोस बनाओ। चलो कौन सी लीड? V1, V2, V3, देन फोर्थ लीड है देखो बेटा, V4, V5, V6 इज ओके, ठीक है। अभी AVL भी देख लो, कुछ दिख रहा है, कुछ नॉर्मल, क्या अबनॉर्मल? नॉर्मल, ठीक है, मोर और लेस नॉर्मल। जो चीज के कह रही है वो है V1, V2, V3, V4। आपको क्या लगता है ये काका का डायग्नोसिस क्या है? पहले कौन सी वॉल और उसकी आर्टरी कौन सी? अगर आपके सामने कार्डियोलॉजिस्ट खड़ा हो तो ये बोल पाओगे? कार्डियक सर्जन खड़ा होगा तो बोल पाओगे? एनेस्थेटिक खड़ा होगा तो बोल पाओगे? That will create your record. Thank you.
Thank you so much, sir, for taking us back to our classroom days. It was an enriching session for all of us. So it's time to felicitate Dr. Deepak Contractor. For that, I would like to invite DC sir and VP Gupta sir. Please give sir a huge round of applause, everyone.
Just to take an opportunity to speak something about it as a colleague physio. After 30 years of my experience, I just see this man who steals the crowd and who has tremendous. Right? So I appreciate his I was struggling to get the cardio students nowadays. Everybody prefer NDT, ortho, neuro, sports, and very few people, North India, especially I'm saying about North India and Central India, very hardly find a cardio student. But I think the teacher like him, if everyone teaches like this, people start coming to join cardio, where there is a lot of scarcity in hospitals with a lack of knowledge in ECG and many more things to study in cardio. Okay, thank you very much.
And one more thing, मेरे सामने बहुत बड़ी चैलेंज थी। Let me tell you, मेरा सेशन चालू होने वाला था और मुझे पता पड़ा कि अब टाइम 4 हो चुका है, मुझे बहुत कंसाइजली खत्म करना है, कंसाइजली। I'll tell you something, आपने जो भी सीखा है ना, ठीक है, वो एक्चुअली 1 डे का टॉपिक जो आपने अभी 15-20 मिनट में सीखा. So operation for yourself. And what diagnosis we are making now, these are the provisional diagnoses. Current, ठीक है, आप ऐसे क्लेम डायरेक्टली किसी कार्डियोलॉजिस्ट के सामने मत कर सकते हो, लेकिन हाँ प्रोविजनली फिजिकल फंक्शनल डायग्नोसिस डिफरेंशियल जो बोलते हैं ना, ये डिफरेंशियल डायग्नोसिस बना सकते हैं, ये डिफरेंशियल डायग्नोसिस आप बना सकते हैं. लेकिन ओवर पीरियड ऑफ टाइम जब आप एक्सपीरियंस्ड हो जाते हो, आपकी आईज लाइक इन अ फुटबॉल, आपको एक एक चीज छोटी छोटी दिखने लगेगी ना, then you can claim that yes sir I know the diagnosis. Understood? है ना? तो ये पूरे एक दिन का टॉपिक है जो मैं कंसाइज करके 15-20 मिनट शायद हाफ एन आवर ले लिया मैंने. No ma'am. No ma'am.
That was necessary.
But this was worth it or not?
Yes.
Thank you. Thank you.
This is a very basic thing. Whether you are an orthophysiotherapist, neurophysiotherapist, or cardio physio, or sports physio, especially sports and cardio, these are the things because the body has one system which is covered by brain and heart. All the organs are being covered by brain and heart. All the hormonal functions, all the gut functions, all the kidney functions, they depend upon the vascular supply. So the heart function, everyone has to know whether it is a primary challenge or not, whether it is a primary emergency or not. If you are treating a diabetic patient, you are making an exercise for quadriceps, and the patient sweats off. You will think that there is a sugar level modulation. First thing. But if the patient is getting breathless and uneasiness, definitely there is a problem with the vascular system. And these patients find it in orthopedics and neuro. The diabetic patients are the most patients which you have to go through, which you have to treat. And diabetic patients are non-STMI patients, which you will find it because they won't feel much symptoms for the heart. And especially those patients who are metabolically compromised, they will have conduction defects. The last ECG which he showed, when the QRS complex was wide, this is a conduction defect, and the patient can go into stroke immediately. Right? So these things are normal things for a health professional. How to identify an emergency situation and how to take care. In BLS, what do you think? BLS we have made in national curriculum when I was making the task force and I was making the curriculum. Yes, now we have made it in second year curriculum. And we are trying for MPT cardio and MPT sports to have ACLS also. So that is the thing, as a health professional, you must face the accountability, you have to face the challenges. And I will congratulate Mehul for a wonderful session.
Thank you all the dignitaries. Now we have come to the conclusion of our ICAP 4.0, the valedictory ceremony. It is not merely a conclusion, it is an opportunity to acknowledge the contributions that made this conference meaningful and to celebrate excellence within our academic and professional community. So we are here to appreciate these individuals who are doing amazing in our field of physiotherapy. For that, first category is outstanding academic achievements, and in that I would like to invite our first awardee, Dr. Sudhakar Vishwas sir. Please welcome sir with a huge round of applause. We appreciate your contribution to the field of physiotherapy. I would request PC sir and Niti Gupta sir to please be on the stage and felicitate our awardees. Continuing in the category of outstanding academic achievement, our next award goes to Dr. Gaurav Agarwal Singh. Please give sir a huge round of applause. Sir is HOD of SGBU College of Physiotherapy. I would request all the students to please appreciate all the awardees. Next award goes to Professor Dr. Madhusudan Tiwari. Please give sir a huge round of applause. Next award goes to Professor Dr. Shantanu Sharma. Thank you so much, sir, for taking out time. Please give sir a huge round of applause, everyone. And in the same category, our last award goes to Dr. Ramveer Saini. Please welcome sir with a huge round of applause. Congratulations, sir. Before we move on to our next category of awards, there is one important announcement from the School of Physiotherapy at UEM Jaipur. As you all know, ICAP brings together the finest minds from our fraternity, and today we have something special to share with this esteemed gathering. We are proud to announce the Physio Fest, a vibrant celebration of talent, innovation, creativity taking place from 31st August to 8th September. We are going to celebrate a Physio Week for the World Physiotherapy occasion. It will include various activities including case decode, muscle puzzle, anatomical painting, health and fitness, content creation, quiz, physiodrama. The registration fee is completely free for this event, so I would request all the academicians present over here to please send their students for the Physio Fest. And I would request every single one of you to please come up on the stage to inaugurate our poster. Please, sir. Please, ma'am. Ramveer sir, Gaurav sir.
Sir, चलिए ना please.
Shantanu sir, Madhusudan sir, please come up on the stage. Prajeet sir.
Sir, चलिए.
Arvind sir, Manish Thakur sir, please come up on the stage, sir. Thank you so much, sir. Thank you so much, ma'am. Moving further to our next category of awards, that is Faculty Excellence. Our first awardee is Professor Dr. Arvind Tomar, sir. Please give sir a huge round of applause, everyone. Continuing in the category of Faculty Excellence, Our next award goes to Professor Dr. Lokesh Sharma sir. Please give sir a huge round of applause, everyone.
The audience must stay back. Hello.
Our next awardee is Dr. Ajit Surana sir. Next awardee in this category is Dr. Shobhit Shukla sir. Please congratulate sir with a huge round of applause. And the last awardee in the category of faculty excellence is Dr. Devendra Singh Shekhawat. Next up, in the category of outstanding clinical achievement, the first award goes to Dr. Amruta Baji. Please congratulate sir with a huge round of applause. In the same category, next award goes to Dr. Akanksha Rajpurohit ma'am. I request all the students to please don't stop clapping. Please appreciate. Next award in this category goes to Dr. Mahesh Sahu sir. Please give sir a huge round of applause. And the final award in this category goes to Dr. Vishwesh Dave. Very congratulations, ma'am.
How are you, sir?
Please give a huge round of applause to Dr. Vishwesh Dave. Our last category for awards is Scientific Committee. We have already felicitate Dr. Anshit Gurnani. In the same category, the next award goes to Professor Dr. Manisha Saharan ma'am.
मैम सर के नाम का सर्टिफिकेट किसी को है क्या?
जी
सर्टिफिकेट
जी सर्टिफिकेट we will provide you later.
kindly कोई एक सर्टिफिकेट. So let's take the pictures. Sorry sir for this.
Professor Dr. Manisha Saharan ma'am in the category of Scientific Committee. And the last award goes to Professor Dr. Ajit Kumar Saharan sir in again category of Scientific Committee. Please congratulate sir and ma'am with a huge round of applause, everyone. For student category, the best student award goes to Mr. Arush Khandekar. He is from JNU. Arush, are you here with us? Please give Arush a huge round of applause, everyone. Moving further, on the first day of ICAP, we conducted our paper presentation competition in that UG PG category. First position goes to Shivani. She is a student from MPT UEM itself. Second position goes to Sariyu Gupta. She is from LPU, student of Tyagarajan sir. And the third position goes to Khushbu. She is a student of DPT UEM department as well. All three of them will receive the certificate online. And in the PhD category, the first position goes to Dwani, who is from Sumanti University. Today we conducted the poster competition, and in that first position goes to Devanshi Bhala. In UG category, she is from UEM Jaipur. Our student from third year. Please give Devanshi a huge round of applause. I request both of you to please take your respective designations, please.
और है
We also have the presence of Dr. Usha Karawat. Ma'am is the principal of Medical College NIMS. We would request ma'am to please come on the stage. We appreciate your presence in ICAP 4.0. Please give ma'am a huge round of applause, everyone. Next up, we would also like to appreciate the presence of Dr. Karawat, HOD Nuclear Medicine, NIMS University. Please welcome sir to the huge round of applause, everyone. Thank you so much for attending ICAP 4.0. Last but not the least, I would like to call all our student volunteers and coordinators to have a group photograph. We will distribute all your respective certificates later on. Please come for a group photograph. All of you, come on, hurry up.
Please be fast. Please be fast. All of you. All of you. Sound technique, right? Okay. Yes.
The knowledge insights gained today translate into stronger clinical practice, meaningful research, and better outcomes for individuals living with cardiovascular diseases and stroke. With that, I formally conclude ICAP 4.0. Let's conclude today with a group photograph of all the faculty members of School of Physiotherapy along with all the awardees as keynotes.
अगले खड़े होके
Yeah.